Let's start with systemic pathology rapid review, and this is going to be full of lots of tables which makes your study preparation a lot faster, concise and simpler. So in blood vessels, the two main topics that we shall be focusing on shall be vasculitis and the vascular tumors, which I've tried to make it as concise in the tabular format as I told you. So let's start with the first one, and that is vasculitis, which we classify as per the Chapel-Hill classification, and that says that when I'm talking about itis or inflammation of the vessels, they are of three types. Either they will involve the large vessels or the medium vessels or the small vessels. So large, medium, small. I'll start with the two large vessel vasculitis, which are T and T. So T and T come under large, that is temporal arteritis and Takayasu arteritis. Should we get going? Let's begin with this journey. Let's start with T and T, temporal and Takayasu. So first I'm starting with temporal arteritis, and these are exactly a glimpse of how the tables are going to be. I'm starting with temporal arteritis, and that is also known as giant cell arteritis. So every word is important, because if I ask you, common sense lagao and tell me what is the most common vessel, temporal arteritis ke liye the most common vessel obviously will be what? The superficial temporal artery. This is common sense that the superficial temporal artery is going to be most commonly affected. And if temporal artery that you can see over here on examination, you can very well see there is a temporal artery thickening. There is a nodular thickening of the temporal artery that you notice. How is the patient going to present? Of course, the patient is going to present with localized headache. There will be headache in this region. So the most common symptom is also done for all of you, hai na? But that was the most common symptom. If I ask you, what is the most specific symptom? The specific symptoms becomes jaw pain, jaw claudication. So remember, most common is headache, but most specific is jaw pain. But what is the most dangerous now? The most dangerous symptom, of course, is going to be if something happens to my vision, loss of vision. So teen cheezein yaad rakho. The most common is headache, the most specific is jaw pain, and the most dangerous, of course, is loss of vision. And how is the patient going to present? There's a nodular thickening, as you can see over here. What will you see on microscopy? Look at the other name. It is a giant cell arteritis. So common sense that the microscopy is going to show you lots and lots of giant cells and granulomas. There is no doubt about that concept. And what is it that will be very, very important is, firstly, can you see these? These are all giant cells. I hope all of you can appreciate. These are all giant cells. So giant cell, the name is only telling me. But what is it that you see on a special stain? On a special stain, we see something known as a VVG stain. So this third wala photo here that has been put up over here. What stain is it? This is the very famous VVG stain. And on VVG stain, you will see there is a black color zigzag line all throughout. But suddenly that black color line is broken. There is fragmentation of internal elastic lamina. That zigzag line that you have, that is nothing but the internal elastic lamina, and that seems to be broken off over here. So fragmentation of IEL is what we notice. Quick 5 questions. Most common is temporal artery, so obviously headache is common. The specific one is jaw claudication. The dangerous one is loss of vision. 3 question ho gaye. 4th question, what are you going to see microscopically? Lots of giant cells. And what are you going to see on a special stain? VVG stain, the fragmentation of internal elastic lamina. So the first T is done. Temporal arteritis ho gaya. The second one is Takayasu arteritis. When I talk about Takayasu, what is the other name? Pulseless disease or aortoarteritis. So I'll start from this name. Why do we call it aortoarteritis? Because I can visualize that over here, the arch of aorta is affected. It is the arch of aorta affected, and they ask you which part of arch of aorta is affected. So the most common vessel is going to be the subclavian artery. The subclavian artery is the most common one that you have. So they realize that I can notice that there is a lot of narrowing. Ye dekho, yahan par these vessels are becoming very narrow. And over here also, when I saw the vessel, if I cut the vessel, it was becoming very, very narrow. So if the vessel is going to become very, very narrow, of course, the pulse is going to be affected. This is going to result in a weak pulse in the upper limb. And that is why we call it as the pulseless disease. Reason for calling it pulseless is that if you palpate the upper limb pulses, they are going to be very, very weak. That is why you call it the pulseless disease. Most common is subclavian artery. They are becoming, you can see them, constrictions ho raha hai. Narrowing is happening. repeating. This is what is known as Takayasu or pulseless. So let me remind you that both these T's were the large vessel vasculitis, and दोनों का नाम you've understood ना. Temporal arteritis is also known as giant cell arteritis, and Takayasu is known as aortoarteritis. So now, which of them is sounding more giant? Common sense, temporal arteritis is sounding more giant ना. So they ask you which occurs after 50 years of age and which occurs below 50 years of age. You will say common sense, the giant cell arteritis is gonna occur after 50 years of age क्योंकि वो giant नाम है, and Takayasu arteritis is gonna occur below 50 years of age. Khatam. Imagine the large vessel vasculitis is finished in 2 tables. Now we go on to the medium vessel vasculitis. For medium vessel vasculitis, we have pan khata bachcha. What is pan khata bachcha? So that means there is pan, there is Kawasaki or khata, and bachcha is Berger's. Repeating, pan, Kawasaki and Berger's come under medium vessel, so I call it pan khata bachcha. Let's get going. In medium vessel, what is pan? Pan or pan that you were calling it, it is polyarteritis nodosa. Polyarteritis nodosa tells us that what is it associated with? 30% cases are going to be positive for hepatitis B. It is positive for HBsAg. And the most common vessel affected are the renal vessels. Medium vessel to hai, but which vessel? Renal vessel. So many people believe that as soon as I use the word kidney, na, they say, acha, glomerulonephritis is happening. No, every kidney disease is not a glomerulonephritis. This is a blood vessel problem. Maybe it is causing something like flea-bitten kidney. Maybe it is causing something else. Every time it doesn't have to cause glomerulonephritis. So if someone asks you that kidney is affected most commonly, but does it cause glomerulonephritis? No. Next, what is the vessel that is never ever affected? So always remember a famous mnemonic, P is not for P. So P is not for P means in polyarteritis nodosa, what is always and always or never ever involved? Never ever involved is pulmonary. Pulmonary circulation is spared. Pulmonary circulation is gonna be spared. It is never ever affected. So repeating, P में P नहीं है. P is not for P. Okay. Coming to the next one. What are you gonna see microscopically? Go back to the first chapter. I've told you all these 3-letter alphabets show you a very, very famous kind of a necrosis. So that is gonna be not everywhere. It is a segmental transmural fibrinoid necrosis. It is segmental, मतलब segments में होता है. It's not like all 5 centimeters of the blood vessel is going to show you. It's going to be seen in segments over here, segments over here. So segmental transmural fibrinoid necrosis. This is, go back to the first chapter. I have taught you all the 3 alphabet things show you fibrinoid necrosis. Okay? So remember these 4-5 points for polyarteritis nodosa. It is associated with hepatitis B. Most common vessel is kidney, but glomerulonephritis nahi hota. The vessel that is never ever affected is pulmonary, and the necrosis that you see, this pink necrosis, is fibrinoid necrosis. Pan khata. So pan is done. Khata becomes Kawasaki disease. Please remember, Kawasaki disease is a bachchon wala disease. Usually occurs in less than kids. Kawasaki is for kids, okay? Kawasaki is for kids. This is a less than 5-year-old kid ka history. And what is the symptoms going to be? One is a mandatory symptom. Mandatory symptom is fever. Fever has to be present in every case. You cannot miss it. So, bachcha hai with fever, that has to be there. After that, there is something that we follow as the CREAM criteria. How many criteria? 5, na? CREAM, 5. Out of these 5, even if any 4 are present, I'll say ho gaya. That is Kawasaki. So what is the mandatory criteria? Fever has to be present, and with CREAM, any 4 have to be present. So what is this? Let's get going. So one by one, I'll tell you all of these. The C stands for conjunctivitis, and for students who've read pediatrics, we know this is a non-purulent wala conjunctivitis. So remember, C for conjunctivitis. R is for rash all over the body. E is for edema, the child will be swollen. A is for adenopathy, lymphadenopathy. So usually they are unilateral cervical lymphadenopathies. Usually they are unilateral cervical lymphadenopathies. And what is M? M is for mucosal involvement. Kaun sa mucosa? You can see the picture in front of you. You can very, very well see the famous strawberry tongue. The mucosal involvement is the strawberry tongue that I'm talking about. Tell me one question from microbiology, that where else can we notice the strawberry tongue? Very, very important. So one condition is in front of you, and that is Kawasaki disease. The other is scarlet fever. Scarlet fever also shows you strawberry tongue. Okay, so repeating, what was the cream criteria? Conjunctivitis, rash, edema, adenopathy, mucosal involvement. Mucosal involvement matlab strawberry tongue, and this is any 4 out of these will also do. But what is mandatory? Mandatory fever, it has to be there. Okay, these are all things which you know since decades. Naya kya hai? What is new information? What is the pathogenesis and the blood tests for Kawasaki that they have found out? So they found out that people with Kawasaki are now known to have anti-endothelial cell antibodies. This is a question that I am expecting in the current exam. Kawasaki disease shows anti-endothelial cell antibodies, and these people usually present with elevated platelet counts. ये दोनों नया information है. Kawasaki kids are coming to us with elevated platelet count and anti-endothelial. Rut low. Repeat it again and again and mug it up. Anti-endothelial cell antibodies are going to be seen in Kawasaki disease. Coming to the last one, there is one complication. Have you ever heard a 5-year-old child having heart attack? So na, very rare na, never heard na. That kind of a complication can occur over here. So please note that these are the kids who are known to have what? Coronary artery involvement. There is coronary arthritis that you notice in these kids, and coronary arthritis matlab these kids are at a risk of myocardial infarction, heart attack, very rare, very deadly. So yeah, this can result in death. So Kawasaki in kids can be deadly also. Always remember, so pan khata, Kawasaki is done, cream criteria should come to your mind. So Kawasaki cream kids, very important. Coming to the next one, pan khata bacha, that is bacha with B-U-E-R, ye wala burgers. I am not talking about the B-E-R wala burgers. They are totally different. What is the difference between B-U-E-R wala burgers and just basically with the U and without the U? That is how we learn it. So with the U wala, when the U is present, I will think of the V. And that is going to be vasculitis. The U wala is the V wala, and without the U is totally different. That is IgA nephropathy. That is going to be the kidney problem. So never get confused. Look at what Burgers is written in the paper. So the U is the V. The U wala is what I'm talking about over here. The U wala is the vasculitis. And what is it also known as? It is also, this is a recent FMG and NEET question both. What is it known as? TAO. Means it is known as thromboangiitis obliterans, TAO. To break the word na, I will say thrombo. There is going to be a blood clot. Bilkul, I can see there is a big blood clot over here. The entire blood vessel is blocked. Matlab obliterated. The entire blood vessel is obliterated. Angiitis means blood vessel. Na? So blood clot is there that has obliterated the blood vessel. So you will ask me, why is there a blood clot, ma'am? Simple na. Burgers for BD. Burgers for BD. So this is associated with smoking. Very important information. Burgers for BD. Easy. What are the vessels? I am saying angiitis. Matlab you will say what vessels? Ma'am, arteries hai, veins hai, lymphatics hai, nerves hai. What kind of vessels of the body are affected? I'll say all the vessels can be affected. Arteries can be affected. Veins can be affected. Even nerves can be affected. What is never ever involved? So always remember, lymphatics are never affected. Lymphatics are never going to be involved. That is a question that you will get. So, sab kuch affect hoga. Lymphatics are never ever going to be affected. So now, clinically, how is the patient going to come to you? So think logically, the blood vessel is obliterated. The entire blood vessel is blocked like this over here. So will the person have pain? Of course, there is going to be intermittent claudication. But after some time, socho, initially, to only the arteries and the veins were affected. So intermittently pain was there. Gradually, I realized that the nerves also start getting affected. So is there going to be pain at rest eventually that will happen even without doing any activity? Patient will say, my legs are aching a lot. Hai na? So repeating once again, there is going to be intermittent pain initially, but as the nerves will get affected, the pain will start happening at rest also, and that is what you have for Burgers. So please remember, Burger with a U is the vasculitis I'm talking about. Burgers for BD, smoking or just smoking in general, is very important, and it is known as TAO, thromboangiitis obliterans. The entire blood vessel is obliterated. So pan khata bacha is done, and I realize that your medium vessel vasculitis is over. Let's go on and talk about the small vessel vasculitis. Under small vessel, there is something called Hinox-Schonlein purpura and there is something called ANCA associated. So starting with the first one, that is Hinox-Schonlein purpura. Firstly, ratta lagao, which antibody is it associated with? Very, very important. Everything that is happening over here is because of IgA antibody. It is nothing to do. Many students believe purpura hai, acha ye dengue fever type of purpura hoga. There's a reddish color rash on the skin, ye wo dengue fever wala hoga, so the platelet count must be low. Nahi, the platelet count is not low. The platelet count is totally normal because this is not a platelet disorder. This is an IgA related disorder. The IgA is getting and going and getting deposited in different parts of the body. So what parts of the body am I talking about? So the mnemonic for Hinox-Schonlein purpura is parpura. ठीक है, थोड़ा Bengali accent में बोलते हैं. Hinox-Schonlein purpura, we are going to call it Hinox-Schonlein parpura. So what is parpura? Because that will tell me there are 4 organs in which IgA is going to go and create a problem. What are those 4 organs? Firstly, P of course for purpuric rash, and these are usually on the lower limbs. Below the buttocks, usually on the lower limbs it is noted. Okay, then there are joint pains, to matlab A for arthralgia, there is abdominal involvement, to abdominal pain, and R for renal involvement. Renal involvement basically means the patient is going to have hematuria. So what is Hinox-Schonlein purpura? Purpura, arthralgia, abdominal pain, renal involvement, of which please note that this renal involvement is the most common. So you get a lot of questions on these. So which is the most common organ affected? It is the renal. So Hinox-Schonlein purpura ka yahi question hai. IgA, most common antibody, platelet count is normal, and the mnemonic is parpura. Remember, this is also gonna be seen in chota bachcha. So Hinox-Schonlein purpura is also seen in children. It's a childhood vasculitis. So this one is done. Hinox-Schonlein purpura ho gaya. The other small vessel vasculitis is ANCA associated. So first you need to know that what are the 3 ANCA associated vasculitis that they ask me in the paper. Then I'll tell you what is ANCA. So the 3 ANCA associated vasculitis are going to be W, M and C. That is going to be Wegener's, microscopic and Churg-Strauss. Ulta chalte. When I'll write Churg-Strauss, please remember, Churg-Strauss is now known as, you might not want to learn the full name, but ek baar dekh lo, you'll get an idea. Okay ma'am, it is something to do with granulomatosis. So granuloma to is seen in every part of vasculitis. Okay. It is a polyangiitis. Polyangiitis matlab blood vessel, understood. It is allergic polyangiitis. That is what I want all of you to focus on. It is an allergic polyangiitis, which means that Churg-Strauss syndrome mein se E banaoge. So this is going to show you a lot of eosinophils. It's going to show you an eosinophilic granuloma. Why? Because I can see the word allergy written in it. So always remember, C mein se you're going to make an E. From C, you are going to make an E out of it, because that will tell you a lot of eosinophils are there. So there is some allergic component involved over here. Easy ho gaya? Let's move on to the next one. Microscopic polyangiitis. You will realize this is the only one where I will not say granuloma. Baki har jagah, every vasculitis shows you a granuloma. Only microscopic polyangiitis is not gonna show you a granuloma. That is your previous year question. That is why nowhere in the name also you're saying granuloma. Granuloma is not noted. What is it then? It is known as a vasculitis. I know that is the topic. Leukocytoclastic. Leukocyte matlab WBC. Clastic means breakage. WBCs are breaking. So there is fragmented WBCs. That is what you see. There are fragmented WBCs, and granuloma is never ever noted. That is what is microscopic polyangiitis. And after that, I don't want to tell you anything, because this is said to be the opposite of pan. Ye pan ka bilkul opposite. What was pan? That pan khata bachcha. So now tell me, revise with me. Jo pan mein tha, microscopic is opposite. So polyarthritis nodosa had HbSAg positivity. Microscopic does not. Polyarthritis nodosa was causing involvement of renal vessels, but was never ever involving or causing glomerulonephritis. No glomerulonephritis with pan. So microscopic polyangiitis causes glomerulonephritis. Polyarthritis nodosa had no involvement of pulmonary. Microscopic polyangiitis has involvement of pulmonary. Polyarthritis nodosa showed you fibrinoid necrosis. Microscopic polyangiitis is going to show you leukocytoclastic vasculitis. Sab kuch ulta hai. It is just the opposite end of pan. So there is no hepatitis B over here. There is glomerulonephritis. there is involvement of pulmonary circulation, and there is no fibrin or necrosis. बिल्कुल उल्टा कर दो, that becomes microscopic polyangiitis. Coming to the last one, Wegener's granulomatosis, that is now known as GPA. Wegener's granulomatosis is known as GPA, means another granulomatosis. See, granuloma word they kept. Granulomatosis rakha, Wegener's hata diya. Instead of Wegener's, they said, let's call it polyangiitis. So granulomatosis with polyangiitis, I have learnt it in simple way. One triad, second triad, khatam. When I say my focus is so much on the word granuloma, where all are the granulomas seen? तो पहला triad क्या है? Where all are the granulomas seen? You will say, ma'am, obviously it's a chapter of the blood vessels. है ना? It's a chapter of the blood vessels, so you will have to keep blood vessel. Other than that, it is seen in the kidney and the lungs. So granulomas are seen in blood vessel, kidney and the lungs. तो ये तो granuloma का triad हो गया. But there is another triad which I call as ENT triad. ENT मतलब E में the patient is going to have otitis media, so ears में otitis media, nose में the patient will have nasal septal perforation, and throat and mouth में there's going to be strawberry gums, as you can see over here. So now note, strawberry tongue was seen where? It was seen in that kid. That Kawasaki kid had strawberry tongue. Whereas who has strawberry gums? Wegener's. Wegener's mein G hai. Wegener's granulomatosis has strawberry gums. Please don't get confused. So repeating, what are the two triads? Firstly, granulomatosis matlab har jagah granuloma is going to be there. That is triad number 1. Granuloma in blood vessel, kidney and lungs. Second is an ENT triad. We'll write it as ENT triad so that you remember. Otitis media, nasal septal perforation, strawberry gums, and Wegener's granulomatosis is done. What was common between all three of these? They were associated with an antibody called ANCA antibody. So now I want all of you to know that what is it about ANCA that you get in the paper. ANCA is going to be anti-neutrophilic cytoplasmic antibodies. Pehle to you have to know their names. Anti-neutrophilic cytoplasmic antibodies. And how many types of ANCA? You have something called cytoplasmic ANCA, where C ANCA. So you can see now the entire cytoplasm is green. The entire cytoplasm. वो बीच में black holes क्या है? तो black holes are nucleus. So nucleus is not green. Cytoplasm is entirely green. Can you see the green color to the cytoplasm? C ANCA is also known as PR3 ANCA. So we learn it as CPR. C ANCA and PR3 ANCA is the same. Okay? Now the second one is P ANCA. What is P? P stands for perinuclear. Only the area around the nucleus. Look at this. Only area around the nucleus is green. Only the area around the nucleus is green. Perinuclear, and that is known as MPO ANCA. So in the exam you get confused. What is PR3? What is MPO? So agar bhool gaye what are the other names of C and P, you will remember the mnemonic CPR, because it will remind you that C ANCA is known as PR3 ANCA, and then the other one P ANCA is known as MPO ANCA. Now where do you see which one of these? So remember, Wegener's granulomatosis में तो इतना सारा triad था ना, it is everywhere. So genuinely Wegener's granulomatosis is everywhere. It is going to show you the C ANCA also, it is going to show you the P ANCA also. Wegener's shows you both, but commonly kaun sa hai? The more common one is going to be the C ANCA. So Wegener's is going to show you World Cup. Matlab C ANCA is seen more commonly. What about the others? What about the others? Microscopic polyangiitis, Scherk-Strauss syndrome. Yes, I can see the others are coming all under the other variety. So simple ho gaya na. For C ANCA, there is only one thing. For C ANCA, you just have to learn Wegener's granulomatosis. That's it. There is nothing else under C ANCA. Everything else comes under P ANCA. P ANCA में सब कुछ है. I call it pan ANCA. Wegener's, microscopic polyangiitis, Scherk-Strauss syndrome, everything comes under P ANCA. In fact, there are two conditions that you have outside blood vessels that are also having P ANCA. One disease of the intestine. Ulcerative colitis also has P ANCA, and primary sclerosing cholangitis in the liver. Repeating, primary sclerosing cholangitis also has a P ANCA. So P ANCA तो मतलब बिल्कुल ऐसा pan spectrum ANCA है, that every disease is gonna come under P ANCA. Wegener's, microscopic, Scherk-Strauss, PSC, ulcerative colitis, everything comes under it. C ANCA is simple, World Cup, one thing. Only Wegener's comes under C ANCA. So let me ask you one question. Wegener's shows you C ANCA, P ANCA, or both? Your answer is both. But if they ask you which is the most common thing that veg nurse show you, तो World Cup याद रखना. So veg nurse is going to show you C ANCA more commonly. And with that, we have wrapped up our entire Chapel Hill classification of vasculitis. I hope everyone's okay with this. Now, having discussed the first topic, that is vasculitis, I am going to take you all and move towards the second topic, which is a chota wala topic known as sclerosis. After that, we'll go to the next big topic, and that is the vascular tumors, okay? So, jaldi se let us make a table of sclerosis and finish it off. It's a very chota sa table that you have to know, that is to do with sclerosis. So, how many types of sclerosis? 1, 2, 3, 4. Karo khatam. How many types of sclerosis do we know? Another table. I told you, na, systemic is all about table and khatam. So one tables I told you for all those vasculitis. Now I'm telling you one common table for sclerosis. So I see a lot of sclerosis that has been written over here. So if they say Hyaline arteriolosclerosis, you will see the blood vessel has become entirely pink. There is going to be pink hyaline material. That is why they called it hyaline arteriolosclerosis. Versus if they say hyperplastic, something is becoming more, hyperplasia ho raha hai. That means I will see this kind of lots and lots of cells going as a round and round. Means I'm going to see the very famous onion skinning pattern. So remember, there is something called hyaline arteriolosclerosis and hyperplastic arteriolosclerosis. Hyaline arteriosclerosis is seen in benign hypertension and diabetes. Hyperplastic, hyperplasia, more cells, more BP. Kitna BP? Malignant wala BP. Malignant hypertension. So hyaline is seen in hyaline benign hai. Hyaline benign, same sounding na. Hyaline benign. They are benign hypertension. Hyperplasia, hyper, बहुत ज़्यादा BP. That is going to be malignant hypertension. Hyaline shows you pink material. Hyperplasia shows you the very famous question, onion skinning. The third one, though, I have studied in my first chapter, Monckeberg sclerosis. I know what is the other name for Monckeberg sclerosis. It is known as CMD, calcific medial degeneration. Where did I teach you in the first chapter? What calcification? It's a dystrophic calcification. So I could see an old age phenomena, degeneration. This is seen in very, very old people. Where is it seen? Media. It is seen in tunica media of the blood vessels. So I hope I'll show you a zoomed in wala photo of this. I hope everyone can see in the tunica media we have the blue color calcium. Na? So this is the blue color calcium that you got to know. So repeating once again, we have calcific medial degeneration known as Monckeberg sclerosis. Break the word, calcific, dystrophic calcification. Where? In the tunica media of the blood vessel. And why? It's just an old age thing. It has no clinical significance, no symptoms, nothing to worry. It's just an old age phenomena. Coming to the last one, and that is atherosclerosis. Now in atherosclerosis, I want to ask you just 3 slides which are important. Slide number 1. How does atherosclerosis develop? So initially you don't see itna bada sa yellow color lesion. No, the first lesion is just a very, very small thing known as fatty streak. The first lesion is just a tiny little yellow line in the blood vessel that is known as a fatty streak. Gradually it becomes something known as an atheromatous plaque. So they will ask you that what is the location of an atheromatous plaque? It is below the intima. It is going to be subintimal. That is what you can see over here. It is below the intima. It is going to be subintimal. Intima, inner layer, na, just below that you will see all that fat, cholesterol getting deposited. So obviously it is because of fat, cholesterol, obesity. Ye sab to pata hai, alcohol, smoking. No one will ask you all these factors for atherosclerosis. They will ask you, are there any infections associated or infections which cause atherosclerosis? Yes, you need to know cytomegalovirus, chlamydia and herpes. Cytomegalovirus, chlamydia and herpes. This is a correlation that I'm telling you from your microbiology, so that over there you don't have to read it again. Repeating, virus mein cytomegalovirus and herpes virus, and then in the bacteria you have the chlamydia. These 3 are infectious causes of atherosclerosis. Sabse pehle there'll be chota sa fatty streak that will become a plaque, and this plaque is what is location? It is subintimal. So after this is formed, now what after it? Ye to ban gaya. What after it? What are the complications that can happen after an atherosclerotic plaque? Complication matlab big time problem. Complication will mean that there is some acute problem that has happened. That is my mnemonic. So what all can happen? Number 1, A for aneurysm can happen. C for calcification. U for ulceration, and T and E for thrombosis and embolism. Repeating, aneurysm, calcification, ulceration, thrombosis, embolism. These are the acute complications that can happen in acute atherosclerosis. ठीक है, atherosclerosis का acute complication is aneurysm, calcification, ulceration, thrombosis, embolism. Second slide done. Last part. What are these vessels that I'm talking about? If I ask you, tell me from the most common to the least common list of vessels that are affected, I've got a very scattered kind of a mnemonic. Na? ACP of Delhi traffic is cute. How cute? Kitna cute mnemonic hai? ACP of Delhi traffic is cute. So this means the most common vessel is abdominal aorta. C se kya hai? Heart, so has to be there. So coronary artery. Then there is popliteal artery. So first abdominal aorta, then coronary, then popliteal. DT, descending thoracic aorta. DT for descending thoracic. I for internal carotid. And C for the brain, the circle of Willis that is present at the base of the brain. So that is the least common vessel affected. So repeating, most common, again we'll say ACP, abdominal aorta, coronary artery, popliteal artery, ACP, Delhi traffic, so descending thoracic is acute. So internal carotid and circle of Willis. So this goes from most common to the least common blood vessels, which is also an important question in the exam. With atherosclerosis done, we are also done with all the 4 types of sclerosis: hyaline, hyperplastic, Monckeberg, and athero. Sorted. We are coming to the last part of the blood vessels, and those are going to be the vascular tumors. Now, I am going to tell you 3 tables for vascular tumors. Vascular tumors are divided into 3 types. One of them are going to be all the benign tumors, which I'll explain to you. Second variety is obviously going to be all the malignant tumors, and then a gray zone wala variety hai in the middle. So that is intermediate category of tumors. Okay, that gray zone, neither benign nor malignant, that kind of a category. So let's get going. I know it's a long table, but it'll solve all your questions. The first 3, hemangioma, and another hemangioma. So pehle to I'm picking up all the hemangiomas out of here. So, if I say in these benign tumors, the first one is a capillary hemangioma versus cavernous hemangioma. Please look at the photo first. ठीक है? Capillary hemangioma मतलब capillary, छोटा blood vessels. You will see very tiny blood vessels which are coming. Lots and lots of tiny blood vessels are gonna be there. So capillary hemangioma, small blood vessels. But when I say cavernous hemangioma, cavern, if you look at the English meaning of cavern means something very big. So cavernous hemangioma is gonna be extremely dilated. Caverns are going to be extremely dilated. They are large dilated channels. So dekho, capillary hemangioma is going to be extremely small size blood channels, whereas cavernous is large blood channels. But how should I differentiate it clinically? Capillary hemangioma will always occur on the superficial side. So for example, they say there is something happening on the skin, on the forearm, on the arm. So skin, superficial wala matlab skin or the mucosa or the tongue, all of these are superficial sites. Whereas if they say that this is happening somewhere in the organs, that is cavernous hemangioma. Most common organ given example is liver. Liver mein kaun sa hemangioma hoga? You will say, okay ma'am, deep seated head has to be cavernous. So if it's superficial, I will talk about capillary. If it's deep seated, I will talk about cavernous. Let me tell you one very important question. Cavernous hemangioma is associated with VHL syndrome, von Hippel-Lindau syndrome. Do you remember the chromosome I have taught you? 1, 2, 3. Deletion 3p. Chromosome VHL, 3 alphabets, third chromosome is gonna be deleted. Sorted with everyone. So one is capillary, one is cavernous. Now let's look at another capillary hemangioma only, but twist in the story kya hai? It is a lobular capillary hemangioma. So I'm gonna see the same chota blood vessels. As you're saying, you'll see the same chota blood vessels, but this time they've made a lobule here, they've made a lobule here, they've made lobule here, they've made another lobule here. So it's the same chota capillary hemangioma, but this time with a lobular configuration, lobular capillary hemangioma. Either you can call it pregnancy tumor, which is the perfect name, because yes, this occurs in pregnancy. You can see this is a pregnant female. They will say there's a pregnant female. That is how the question will start. On the gums, on the fingers, on any part of the body, there is a vascular tumor in pregnant female. So pregnancy tumor to theek term hai. Is it a pyogenic granuloma? Is it pyogenic? Tell me. Is it something to do with the bacteria? No. Am I showing you any granuloma and giant cells in it? No. तो ये तो पूरा गलत नाम. Pyogenic granuloma is a misnomer. It is not a bacteria. It is not a granuloma. गलत नाम. There's another name to it. Granuloma gravidarum. Again, galat naam. Granuloma. Is it granuloma? Is it giant cells? Granuloma. TB wala? No. But is it gravidarum? Is it pregnancy? So this is half wrong, half right answer. So now when they say it's a pregnancy tumor, I agree with them. When they say it is granuloma gravidarum, granuloma to nahi hai, but gravidarum hai, to half I agree with them. Pyogenic granuloma though totally wrong. I don't agree with them at all. So lots of name given, lot of controversy. What is sure shot is that it is a pregnancy tumor. I hope everyone's okay with the hemangiomas. Let's move on to the lymphangioma. This question I have already taught you way back in your genetics chapter, recall. Lymphangioma, the only lymphangioma that you have to know is the one that occurs in the neck. Remember I told you turn the neck. तो टर्नर सिंड्रोम में नेक पर क्या होगा? There is something called cystic hygroma. Cystic hygroma is nothing but lymphangioma. So remember, turn the neck. Turners में neck is very, very important. The neck shows you cystic hygroma, lymphangioma, the only question that comes. Next comes a glomus tumor. What is glomus? Ratta lagao. First ratta lagao these two things. Glomus tumor occurs here. It occurs on the nails, point number 1. And point number 2, it is very, very, very painful. Have a look at this picture, guys. This is what a glomus tumor is going to look like. So firstly, I told you the location is nail bed, subungual, and the pain levels are going to be shouting and screaming with pain. That is just chota sa 1 centimeter tumor and the patient will be shouting his lungs out. That is going to be a glomus tumor. So glomus is going to be like very, 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 very painful history will be given. And these are the two catch points. A subungual, tiny little tumor with lots of pain, glomus. Coming to the last one. This I've only got for your microbiology correlation. Bacillary angiomatosis. If you break this word na, bacillary matlab koi to bacteria hai. What bacteria? B for B, Bartonella henselae. And angiomatosis matlab kuch blood vessel proliferation. So you will say this is common sense. Angiomatosis means blood vessel ka problem. Bacillary means bacteria ka problem. Bacteria we have studied, that is Bartonella henselae. There is a question that you have about Bartonella henselae in micro. What else does Bartonella henselae cause? Do you remember Bartonella was also causing that cat scratch disease? Hai na? That's why I've got a cat over here. Bartonella also causes the cat scratch disease, and now I'm saying Bartonella henselae also causes this blood vessel problem, bacillary angiomatosis. So in microbiology, they ask you what is the special stain for Bartonella henselae. The special stain for Bartonella henselae is Warthin starry silver stain, WSSS. Warthin starry silver stain is what you have in Bartonella henselae. So all these silver stain, na, whenever I use the word silver, matlab black, black, black. So there's going to be a lot of black stuff over here. That is Bartonella henselae. So they could ask you a question. The special stain for Bartonella henselae is Warthin starry silver stain. All the benign tumors in one go. Capillary hemangioma, chota blood vessels, superficial sites. Cavernous hemangioma, big blood vessels in very deep sites. Lobular capillary hemangioma to do with pregnancy. The only lymphangioma in the neck that I have to know, turn the neck, Turner's syndrome known as cystic hygroma. Glomus tumor, nail bed, very, very painful. Bacillary angiomatosis, bacillary matlab Bartonella henselae, angiomatosis means blood vessels. Benign tumors are sorted. I move on to now the next category, that is intermediate tumor. There's only one that you have to know, and that is going to be Kaposi sarcoma. So intermediate tumor, Kaposi sarcoma. We are champs of Kaposi sarcoma. We've read it so many times. Can you tell me what is the organism for Kaposi's? It is human herpes virus 8. And which condition do you see it in? You see it in some kind of HIV positive or immunocompromised individual. HIV positive or immunocompromised individual shows you Kaposi sarcoma. What is the most common site? The skin of the lower limb. The skin of the lower limb is the most common site, and the second most common site is going to be the lymph node. So, ये तो 4 one-liners हैं which are like tick, tick, tick. You know it. The most common organism, human herpes virus 8, usually seen in an immunocompromised patient. Lower leg, lower limb is the most common site, and lymph node is the second most common site. You're gonna see lots and lots of blood vessels. A blood vessel tumor hai, so blood vessels to hoga. Of course, that is what you have for Kaposi sarcoma. Students appearing for higher institute exams, please note on IHC this is LANA positive. This is not important for FMG students. For NEET, okay, but INI-CET ke liye very important. These are going to be positive for LANA that you notice. LANA positivity, Kaposi sarcoma. Moving on to the next, the last variety of tumors that we have are going to be the malignant. So intermediate bhi ho gaya. Malignant mein there are just two tumors that you have to know and we wrap up this story. One is angiosarcoma, which I have already taught you. Especially angiosarcoma of the liver I have taught you. Sarcoma matlab malignant. Which chemicals? Liver ka vat lagega. That is how we had learnt it. Liver ka vat lagega means what? There is going to be vat chemicals. What chemicals cause angiosarcoma of the liver? So it is V for vinyl chloride, A for arsenic, and T for thorotrast. Go back to your neoplasia chapter. We have studied this even in the rapid review, we have studied this in a lot of detail. So remember, vinyl chloride, arsenic, and thorotrast are going to cause angiosarcoma of the liver. The last malignant tumor, hemangiopericystoma, the only possible question on this entire planet on hemangiopericystoma will be this picture. Because if you look at the blood vessels, they are going to look like horns of a deer. It looks as if blood vessels ka aisa jo shape hai, that is like the horns of a deer. So you call them the staghorn or fish hook blood vessels. You are going to call them the staghorn. So staghorn means like the horns of a deer or like a hook. So staghorn or fish hook blood vessels are seen in hemangiopericystoma. That wraps up your malignant tumors also. I'm going to ask you a very quick question. Let's see how many of you were listening to me. There's a 45-year-old male patient who presents with a subungual mass of 1 by 1 centimeter and the patient complains of excruciating pain. Both the buzzwords are there. There's pain and there is a subungual mass, means we are dealing with a case of glomus tumor. There is no doubt about this, right? Well, that was a quick revision question that I had for all of you so that you're sorted. Vascular tumors are done, which also means, guys, for all of you, all your blood vessel review is over. You can jump up to the next chapter quickly, and that is going to be cardiac pathology. The next chapter in which we'll be talking about is going to be the cardiac system. Now, there are some set questions which have to come from path and medicine when it comes to this chapter. You have myocardial infarction, you have cardiomyopathies, you have endocarditis and the cardiac tumors. So let's get going, and you know what exactly is in front of you on the screen, and those are the myocardial infarction ka cardiac markers. So you have a table, you have to mug it up. Let's get going right away. So when we're talking about MI or heart attack in general, we must know this table for MCQ as well as for our day-to-day practice, that what are the markers and how are we going to learn them, what is their order of appearance. So all of you have seen this table, you know I'm going to discuss this table, but first you should know how do I learn which marker comes after what. So what was your mnemonic? MI is definitely a cardiac emergency, my time to call the ambulance, hai na? So that is your mnemonic, my time to call. So the first marker to rise is going to be myoglobin, but I never ever use it in day-to-day practice. Why? Because myoglobin is very, very non-specific. Even if it's some skeletal muscle injury, even if it's road traffic accident, then also the muscle will get crushed. This will come in the blood. So it's nothing significant or specific for MI. I don't use it too often. So my time 2. So time 2 are two troponins, troponin T and troponin I, out of which more, please remember if they ask you which is the more important one. So the more important one is going to be troponin I. So remember I for I, more important, troponin I. My time to call. So C is the next one to rise, that is CKMB. The next one is going to be AST and the last one is LDH. Why have I written double L? Call me double L, na? So double L sounds like L and L, so that is L1. It is LDH1 that is going to rise in the blood. Now please note a very important point over here. In normal human beings, normally someone who's not had an MI, agar unka blood sample you will take, so normally in someone's blood you will realize that LDH2 is always greater than LDH1. If I take my blood sample right now as a normal person without any disease, my LDH2 will be more. But as soon as I'm dealing with a patient of myocardial infarction, physician and I take his blood sample, I will see that there is flipping. I see that LDH1 becomes more than LDH2, and that is why sample, what measurement am I doing? I'm always doing a measurement of LDH1 when I'm dealing with a case of myocardial infarction, because MIMA LDH1 rises, and that is known as flipping of the LDH ratio. That earlier 2 was more in the blood, now 1 is more in the blood, so the ratio has flipped, ulta ho gaya, that is flipping of LDH ratio. So remember, the way you write call mein double L na, to L1 is how you will, LDH1 is rising. Now let's look at the same thing with the help of a table. Look at this, my time to call. So my time to troponin T and I call, that is CKMB, AST and LDH1. So if I see myoglobin, the most useless wala, is rising also very early and is falling also very early. It rises within 2 hours, but within 1 day it is out of the blood. So it's not at all useful. If my patient comes on 2nd day of a heart attack, he will not have myoglobin levels in his blood. I will never be able to find out that he suffered from a minor heart attack. So remember, 2 hours it starts, 24 hours it is vanished from the blood. Not at all useful. Troponin and CKMB, as I see, they start rising almost almost within the same 2 to 4 hours they start rising. But when they fall is very different. So look at this. When I say troponin, troponin sounds like 10. Okay, so troponin 10 days tak, it falls by the 10th day. Whereas CKMB has 4 alphabets na, so anytime before 4 days. What is before 4 days? 48 to 72 hours is 2 to 3 days na. So anytime before 4 days it's going to fall off. That is how I learned it, that both of them started rising almost 2 to 4 hours, but troponin 10 falls by the 10th day, T10, troponin 10. CKMB 1, 2, 3, 4. So that is going to be within less than 4 days. Now we come to the other ones. We come to AST and LDH1. Learn any one of them and the other one is double. So if you learn that AST rises within half a day and falls by the 5th day, what did you learn? Half and 5. Half day, 5 day. So LDH ko double kar do. Half ka double is going to be 1, so it rises in 1 day, and 5 ka double is 10, falls by the 10th day. So repeating, if AST rises by half day and falls by 5 days, then LDH is going to rise on the 1st day and fall after 10 days. So double hai na, that's all that you have to know. Your table is done. So myoglobin 2 hours and 1 day gone. Troponin CKMB rise in the same time 2 to 4 hours, but troponin T10, so it falls by the 10th day. CKMB falls before the 4th day. Then AST is going to be half day and 5 days, so LDH is double, 1 day and 10 days. That is what completes your table. But if they ask you out of all of these, what is the marker of reinfarction? So all of you should be knowing that now it is very, very obvious that the marker of reinfarction is going to be troponin. That is the Harrison update. If someone has a second heart attack, marker of reinfarction is going to be troponin. T and I may say, of course, I is the more important one. These are your cardiac markers. Also, there is an update time. Very, very important. So what do you need to know about update over here? So update time, what is it that you have to know? There are 2 new markers that have come up, which are, they are saying they are even going to rise faster than myoglobin. They rapidly rise in the blood. One of them is going to be IMA, that is ischemia modified albumin. Although not many people are using it, ischemia modified albumin, IMA is how I called it. They are saying that also rises very, very quickly even before myoglobin. And the other one is known as heart fatty acid binding protein. Heart fatty acid binding protein, that is HFABP, those are also going to be, this is also elevated very quickly. Although if I honestly tell you, is it being used too much in practice? No, we still rely maximally on the troponins only. But just telling you know that even molecules rising before myoglobin are IMA and HFABP. I hope everyone's okay with the cardiac enzymes, because now I'm going to move ahead and tell you about 2 things. What if the patient dies? What are all the autopsy findings going to be? So now, if I have an autopsy in front of me, I can have 3 ways of looking at the heart. Either I can look at it with my naked eyes, or I can look at it with the light microscope, the usual one, or I can look at it with an electron microscope, right? So first and foremost, when I'm looking at it with an electron microscope, because electron microscope is very, very advanced now, it can look at very minute, tiny little changes. So please remember, the earliest electron microscope is seen within 30 minutes, means when the person is still in reversible cell injury, even in that much time, within 30 minutes, I will be able to see 2 things on electron microscope. One is going to be the relaxation of the fibers or you can say which fibers? Muscle fibers. Na? So relaxation of the myofibrils as well as mitochondrial swelling. These are the two things that you see on electron microscope, one of the earliest findings to occur, because I've told you what injury? Reversible injury. Reversible cell injury mein to everyone knows from the very first chapter that hydropic change happens, everything starts becoming watery, water balloon jaisa, swollen up. So there is going to be relaxation of the fibers and mitochondrial swelling that you see within 30 minutes, but only seen on electron microscope. So when will I start seeing things on light microscope? After 30 minutes of heart attack. So from 30 minutes to 4 hours, if someone dies and an autopsy comes to me after 30 minutes of chest pain, within 4 hours of chest pain, if the person dies, the first light microscopic change that I'll see will be VV wala sound. What is VV wala sound? That is going to be waviness of the fibers, waviness and vacuolization of the fibers, waviness and vacuolization of the muscle fibers. That is the light microscopic. Let me show you the waviness. Have a look at this picture. Can you all notice how the cardiac muscle fibers have become wavy like this? So when you start seeing waviness and vacuolization of the cardiac muscle fibers, here you go. That is one of your first light microscopic changes which you see after 30 minutes or within 4 hours. So you realized that till 4 hours I am not seeing any gross change. Gross means what you see with your naked eye. So for example, if this is the heart, what can I see with my own two eyes? Till 4 hours of a heart attack, I can see nothing. I can see nothing out of it. So remember, gross has 1, 2, 3, 4, 5. 5 alphabets, na? Means gross change will be seen after 4. After 4 is 5, hai na? So gross change is seen after 4 hours. And that after 4 hours change is known as occasional, just a little bit of color change is seen. Occasional mottling is noted. Occasional mottling is noted. You can see, if you want to know what is mottling, you can see mottling is that slight color change that has started happening. This slight color change is known as occasional mottling. This is the first gross change. So you would want to ask me, na ma'am, matlab, why is this color change happening? What is the correlation microscopically with it? So if you want to look at it under the microscope, put your common sense. Which necrosis are you going to see? Let me ask you a question from the first chapter. Guys, what is the necrosis in the heart? Heart, solid organ. Solid organ ka necrosis kaun sa tha? Coagulative necrosis. Coagulative necrosis is nothing but when you see coagulative necrosis under the microscope, you are going to see mottling in the gross findings. So that wraps up all of your changes. Repeating once again, earliest electron microscopic change seen within 30 minutes, it is relaxation and swelling. Then light microscopic change, VV wala, waviness and vacuolization, which you see after 30 minutes but within 4 hours. 4 hours ke baad 5 letter wala cheez dikhega, that is gross change is noted. So now you've done all these changes, but there's a pertinent question over here. Till 4 hours, what if the person dies within 4 hours? How will I see? With my two eyes, I can't see anything. But can I put some stain? Can I put some gross stain and find out? So the name of that stain is TPTC, triphenyl tetrazolium chloride. Why did I call it TPTC? 4 alphabets. So 4 hours tak, till 4 hours. Till 4 hours, this is very, very useful. You know why? Because till 4 hours, with my own two eyes, though I can't see anything. With my eyes, I'll see, oh, the heart is looking normal. So, for example, if this is the heart, let's consider this fist of mine as the heart. So, if this is the heart and I look at the heart, I say within 4 hours, if the patient is dead, I'll say the heart is looking totally normal. So, what should I do? I'll take a paintbrush and I'll paint it with TPTC. I'll paint it with TPTC, and you know what TPTC does? TPTC stains LDH1. Now tell me, does the normal heart have LDH1? Yes, the normal heart has LDH1. So now you are going to say that, okay, normal heart mein LDH1 hai, so I am going to get a brick red color, which you can see over here. I can get a brick red color with a normal heart. Whereas when I'm dealing with a case of myocardial infarction, all the cells have died. MI matlab death ho gaya na? LDH1 is leaked out. all the LDH1, if the cell has died, obviously all the LDH1 has gone out into the blood. Heart mein se to it has been leaked out. So now that area is going to look pale. So what I see over here is that pale area. This is the area of myocardial infarction. So repeating, this is the brick red area that we have, which means a normal heart hai. And this is the pale area that I have, which is the myocardial infarction heart. If you're wondering what is this pearly white area, this must be some old scar. Maybe this patient has had an MI earlier also. This is probably some old scar that you have. So repeating, brick red area, LDH1 normal hai, sab kuch normal. Red means normal. Pale area means that is the area that has undergone MI. Can I use this after 4 hours? Yes, you can even use it till 12 hours and 24 hours. Using it is not a problem. But the thing is that after 4 hours, so you can see with your own 2 eyes otherwise also. You don't need any special technique. Till 4 hours, you need this 4-letter thing. Triphenyl tetrazolium chloride, because till 4 hours with your own eyes you were not able to see anything, hai na? This is a very, very, very important question. You know, it's come a million times in your previous year papers. That wraps up all of this. So you'll say, fine, 4 hours and all story is done, but when does the repair process start? What is repair said to be? Guys, repair is said to be granulation tissue, hai na? So they ask you, in a case of myocardial infarction, granulation tissue comes on which day? Granulation tissue comes on the 7th day. How will you identify granulation tissue in the exam? Granulation tissue is something very, very rich in blood vessels. The blood vessel amount is going to be immense. Matlab repair has started. After the 7th day, granulation tissue will come, blood vessels will come, the repair has started. Now moving on, after the repair has started, what is it going to process in? After 10 days, what happens? Scar formation starts. So abhi scar ke liye, what is the stain that I always do? Whenever I want to pick up this collagen or any kind of scar, I always use the Mason trichrome. What is the purpose of doing Mason trichrome? You will say, ideally ma'am, there are 3 colors, red, blue and black. I'm focusing on 2 colors for the time being. I want to ask you what comes red and what comes blue. So I had told you that learn Mr. That muscle is going to come red, and then obviously the one that is left, collagen, is going to come blue. So we had learnt it as a Mr. mnemonic. Now muscle is red, and I can see that. Look at this, the muscle, the cardiac muscle part of it is coming red. Muscle is all red and all the collagen part is coming blue. So matlab scar to has started. The scar formation has basically started, and that is how I will look at a scar when I talk about MI. So remember, repair process starts by what day? By 7th day granulation tissue comes, and the scarring is going to be after 10 days, and then scar will develop over the next 2 months. These are all the findings that you have to know when it comes to myocardial infarction. Of course, the table was very, very lengthy. If you want to go through the entire table, you can definitely go through the main videos. That is going to take approximately half an hour, 40 minutes for you to cover, because that is in too much of detail, and of course needed detail if you've read it once. But if you've read it earlier, you wanted a recap, this is the best possible day-wise, hour-wise recap that we have done. The last point that you have to know is, what is this? And honestly telling you, even if you read this much, you're good to go. Now telling you what is reperfusion injury. What is reperfusion injury? So I'm going to draw that primitive diagram that we used to draw for heart in school. And we say that, okay, it is being supplied by some blood vessel, coronary artery banaya. But coronary artery was basically having some kind of a blood clot, atherosclerosis. Atherosclerosis hua, that is why this patient was having a heart attack. Okay. What will you do? You will say, ma'am, either I will give some drugs or I will give some stenting. I will open that blockage. My basic concept is open the blockage so that the blood supply goes back. Now, till the time you do all of that, you start giving drugs to the patient, stenting ke liye prepare karoge. Don't you feel a lot of free radicals and calcium has gotten deposited over here, hai na? A lot of free radicals and a lot of calcium kept on, like, it's like there's a barrier and people are standing behind it, that as soon as this barrier will open, we will run inside. That is what happens in India outside all the monuments, that there's a barrier. As soon as they open the barrier, people run inside. So same way, this is a barrier, the clot, and blood is not going abhi. So a lot of free radicals and calcium are standing over here. As soon as you will remove the barrier, guys, as soon as you will remove the barrier, don't you feel, matlab you gave some drug, thrombolytic therapy, some stenting you did, as soon as the barrier was removed from here, you realized that because of this removal, now all these free radicals and calcium are going to rush to the heart, and imagine heart suddenly gets a lot of calcium. Calcium matlab the muscle will start contracting. The heart says party time, itna calcium, let me contract fully. I've got so much of food, so much of energy, let me contract. And in that process of contracting, it contracts. So like for example, you go to the gym and you're first of every month you say na, healthy diet, healthy knee, healthy lifestyle. You go to the gym and you straight away go and pick up a 20-kilo dumbbell on the very first day. What are you going to have? Muscle injury. Same way, so much of calcium comes, the cardiac muscle gets so excited, ekdam se contract hua, and there is formation of contraction band necrosis. There is formation of contraction band necrosis. It contracts so hard that it ends up getting damaged. This is known as reperfusion injury. Reperfusion matlab you gave a therapy and in turn patient ended up having injury. So reperfusion injury is what is gonna be noted over here. So repeating once again, this is because of increased free radicals and calcium. Free radicals, of course, a more deadly thing out here. Okay, so on that note, can you quickly answer one question, guys? Here you have a 61-year-old female who's presented with left-sided chest pain radiating to the left arm and jaw. The pain has increased severely in the last 40 minutes. Patient is rushed to the hospital. Cardiac enzymes are elevated. Matlab MI ka case hai. Patient is started on some thrombolytic therapy. However, on day 5, the patient collapses and dies. Patient could not be revived. What is the kind of necrosis that you see? Even if you would have read the last line first, you know the necrosis that you see in the heart is always and always going to be coagulative necrosis. So this just shows how a lengthy question from medicine will come and how the answer will be somewhere hiding in pathology. Let's pick up one more question. There is an autopsy diagnosis of myocardial infarction that needs to be done by immersion of the tissue slices in a solution of what? So for MI, what is the gross stain that we have? I think everyone knows TPTC. TPTC is triphenyl tetrazolium chloride, and what does it stain? It stains LDH1. So this was a simple question, hai na? So this basically wraps up our MI. We've done the cardiac enzyme, the autopsy findings we have done, we are sorted with it. Now let's move on to the next topic, and that is going to be the carditis. Now when I say carditis, I've got you a list 1, 2, 3, 4. ये पढ़ना है. Jaldi let's start off. ठीक है? When I say carditis, I have 3 layers of the heart: pericardium, myocardium, endocardium. So pericarditis, the only question that I'm expecting on pericarditis is, where do you see fibrinous or serofibrinous pericarditis? Either of the two words will be written. Fibrinous or serofibrinous pericarditis, which is also known as, why have I got that bread and butter over here, the famous hostel food, which is also known as bread and butter pericarditis, is seen in which disease? It is seen in rheumatic heart disease. Rheumatic heart disease shows you a pericarditis called fibrinous pericarditis, known as bread and butter. It looks like bread and butter, and it is bread and butter matlab butter aisa stretchy hota hai na, so the fluid is fibrinous. Fibrinous matlab the fluid is going to be stretchy. So bread and butter pericarditis is seen in rheumatic heart disease. Tick mark. Next, what is the question that you'll get on myocarditis? So please remember, myocarditis is associated with certain viruses and myocarditis is associated with certain parasites. The list is never ending. I'm telling you the most important thing. Viruses may always remember, Coxsackie is one very famous virus. And herpes is also famous. Herpes and Coxsackie very famous. Talking about parasites, most important, Trichinella spiralis. Go to your microbiology portion and you will know that this is very important. Trichinella spiralis, very important to cause myocarditis. So viruses and parasites cause it. Coming to the last one, and that is endocarditis. But actually endocarditis is of 4 types. Rheumatic heart disease, infective endocarditis, NBTE and LSC. एक करके करते हैं. When I say rheumatic heart disease, I hope everyone knows. Rheumatic heart disease is caused by group A beta hemolytic streptococcus. It is caused by group A beta BHS, है ना? Group A beta hemolytic streptococcus, which is nothing but Streptococcus pyogenes. You have studied this in microbiology. Very important. I'll talk more about it. Infective endocarditis can be caused by Staph aureus. Infective endocarditis can be caused by Streptococcus streptococcus also. So infective endocarditis has lots of infections. So you realized rheumatic heart disease भी infection ही है, infective endocarditis भी infection ही है. So now I need something which is not to do with infections. Non-bacterial thrombotic endocarditis or merantic endocarditis is not to do with infections. This is seen in association with a very famous leukemia called AML-M3, very, very important leukemia in pathology. And lastly, Libman-Sachs endocarditis, the way you write LSC, if you rearrange the terms, this is seen in LSC. LSC is seen in SLE, rearrange the alphabet. So Libman-Sachs endocarditis is seen in systemic lupus erythematosus, SLE, and that is what wraps up endocarditis ka 4 types. So now it's important that you look at the vegetations. Whenever I say endocarditis, any endocarditis on this planet, all of them are going to have something called vegetations. So all these yellow dot things that you're seeing everywhere, these are all said to be vegetations or verruca. These are all said to be vegetations or verruca. So let's get going. First one is rheumatic heart disease. How are the vegetations? I can see the vegetations are very, very small. They are small, warty vegetations, tiny vegetations that are going to be present. Also, please note that these vegetations are along the lines of closure. Can you see? They are all along the lines of the valve. These yellow vegetations are all along the chota dot vegetations along the lines of closure. Is this an infection? You'll say, of course, ma'am, rheumatic heart disease is an infection, streptococcus pyogenes. But if I say, is streptococcus pyogenes in the blood, in the body? Yes. But is streptococcus pyogenes inside this vegetation? If I pick up one bit of this vegetation, is streptococcus sitting inside it? No. That is why I say it is a sterile vegetation. Sterile matlab the vegetation does not have the bacteria sitting in it. It is a sterile vegetation. And finally, is it going to spread anywhere? It is not going to spread. So simple, chota innocent. That is how I have learned. Rheumatic heart disease, chota innocent vegetation. Tiny vegetation sitting along its territory, not going anywhere, not undergoing embolization, not at all infected. Chota innocent. Whereas infective endocarditis, big bad. Big bad matlab, look at the size. It's big and bulky. It's going to be big and bulky. Is it sterile? No, the word only tells infected. This is non-sterile. You will be able to see the bacteria in the vegetation. The bacteria will be present, and also it is so big and bulky. Look at this. It is so big and bulky that it will break and go to other parts of the body. Is it gonna embolize? Yes, embolism is possible. It can go to other parts of the body by breakage because it's so huge. And like I said, big bad. Big bad matlab it is big and bulky. It is gonna be bad because it will go to different parts of the body, and it is going to have bacteria also. It is non-sterile. Big bad vegetation is infective endocarditis. Coming to non-bacterial thrombotic endocarditis, which we also call as merantic endocarditis. Please note, their main feature is fragile. Their vegetations are very weak and fragile, breaking wala vegetations. So if something is constantly going to break, of course it's going to spread to different parts of the body. Of course it is going to show you lots of evidence of embolization. And once again, it is sterile. It has no bacterial growth. Bacterial growth abhi tak sirf ek mein tha. The big bad bulky one had bacteria growth. The others, no one has bacterial growth in it. Coming to the last one, LSC. LSC, I told you, rearrange the terms. You're going to see it in SLE. And these are very important because these vegetations are seen on both sides. These vegetations are seen on the upper side of the valve also. They are seen on the lower side of the valve also. So when I say LSE, all of you will remember E for everywhere. Where do you see the vegetations? I see them everywhere, but LS matlab lower surface. Where are they more commonly seen? They are more commonly seen on the lower surface. Will you remember LSC very clearly? That LSC mein E for vegetations are seen everywhere, upper side also, lower side also. But where are they seen more commonly? They are seen more commonly on the lower surface. And finally, are they going to spread anywhere? No. Are they going to be sterile? Yes. So overall, I realized if I had to make an analysis out of all four of these, which is the only one which is having bacterial growth, which is having bacteria, non-sterile. So a big bad bulky one is showing bacteria. Rest all of them are sterile, innocent. Only this one has the bacteria in it. Next, which is the only one? So I'll put a box over here. Next, which is the only one out of these which can spread? So remember, these two can spread. these two can spread. One, the fragile one, NBT, weak hai, fragile hai, so it will break and spread. Of course, it's gonna spread. Second, the infective, the bad, bulky one can also spread at times. So these two are the ones which can show embolization. Next, rheumatic heart disease is chota chota warty. Infective endocarditis is big, big, bulky, bad. Then NBTE is weak and LSC is everywhere. But which is the more common surface? The lower surface is more common. I hope everyone's clear. This table will come in medicine and path. It's extremely important. Out of these, I want to talk about these two in a little bit more detail about their criteria. There is something called rheumatic heart disease, and for rheumatic heart disease, we have the very, very famous revised Jones criteria, which you have in medicine also. Jaldi se should we revise the medicine part? When I say revised Jones criteria, there is a major criteria, there is a minor criteria, and then there is a supporting evidence. Okay, so what is the major criteria? So I said, how will students learn major criteria? I said that for major criteria, they should be knowing that the major criteria is the name of the criteria, Jones criteria. So mnemonic is Jones criteria. So first, J and O. O are gonna mean joint. Joint mein kya hoga? Migratory polyarthritis. So JO for joint. What is N? N is some nodules, subcutaneous nodules, no pain. I told you na, RHD is very, very chota chota innocent. So sab kuch innocent chalega, no pain. Painless nodules are gonna be there. What is the E standing for? The E is a skin problem, erythema, erythema marginatum. What is S? Sydenham's chorea. Sydenham's chorea. And what is criteria? This is my favorite. It is carditis. Now many students ask me, kaunsa wala carditis? I say pancarditis. Pancarditis means everything. Pericarditis, myocarditis, endocarditis. All the three layers are going to be affected. So repeating, what is Jones criteria? Joint, migratory polyarthritis, subcutaneous nodules, innocent, painless, erythema marginatum, Sydenham's chorea, and pancarditis. That is what you see in the major criteria of this. What is the minor criteria? Chota chota things. Kya acha hai to bacteria. Bacteria will cause fever and ye sab jo blood tests hoga. So what are all the minor criteria? You will say that, ma'am, think from bacterial point of view. So if there's a bacteria, bacteria will cause fever, bacteria will cause joint pains. So fever and arthralgia to hoga. What is the ECG finding? Very important. Prolonged PR interval is seen in rheumatic heart disease. And when you come to the pathology findings, inflammation hai to inflammatory markers will increase. C-reactive protein and ESR will be elevated. So the minor criteria is basically to do with all the common sense wala things, that okay, it's a bacterial infection, so bacterial infection mein CRP and ESR will rise, bacterial infection mein fever and joint pains will occur. One additional things that you have to know is going to be the very famous PR interval. Okay. Lastly, you say that, ma'am, I also need a supporting evidence. What supporting evidence? Supporting evidence that was there a streptococcal pyogenes infection. How do I document it? I will have to give you in written that streptococcal infection was there in your patient. How should I prove it? Either I will prove it by testing for the antigen, a rapid antigen test, or I will test for the antibody, anti-streptolysine O antibody, or I will grow the organism. Organism grow karna hai. From where should I take the sample for streptococcus pyogenes? Because right now you're thinking of cardiac and all big, big things. But chota socho na. Streptococcal pyogenes first goes where? Pharyngitis. So from where should I take the sample? I should take a regular throat swab culture. So either of the two. Either you can give me evidence in terms of antigen, rapid antigen test, or antibody, that is anti-streptolysine O, or the organism, that is the throat swab culture. And that is going to be the revised Jones criteria. So they say that supporting evidence to dena padega. Supporting evidence under any circumstance, you will have to document that streptococcus infection to hua tha. Out of major and minor, either you have two major or you have one major and two minor. So either you have two major or you have one major and two minor. I always learn these major minor as capital M small m so that exam mein yaad rahega. Either two major or one major and two chota chota minor ones. But whatever may be the situation, evidence to dena hai of streptococcal infection. I hope everyone's okay with this, because now I can ask you 4 more one-liners. If you're dealing with a case of rheumatic heart disease, what is the most common valve that is affected? That is the mitral valve. The least common valve affected is the pulmonary valve. Both of these are previous year questions. Most common mitral valve, least common pulmonary valve. So let's take the example of the most common mitral valve का example लेते हैं. तो acute starting में the mitral valve will have mitral regurgitation and long cases में the mitral valve will close. Mitral stenosis will occur. So what am I saying? This was the mitral valve. In long-term cases, it closed. कैसा लग रहा है? Is it looking like initially it was open, big mouth, and now it is closed. It's looking like a fish mouth. This is gonna result in a fish mouth valve. Fish mouth, or some people also call it the buttonhole valve. So please remember, this is going to result in fish mouth or buttonhole valve. You can have a look at this picture over here. Look at this, very, very famous. Can you all see that the valve has become very narrow? It has become as if it's shut off. So that is the fish mouth or the buttonhole valve that you see when there is a case of mitral stenosis. So initially there is mitral regurgitation and later on there is mitral stenosis. But now one thing you forgot. You said, सब कुछ देख लिया ma'am. I have read everything about rheumatic heart disease, but the most characteristic part of rheumatic heart disease we have not studied. What is the most characteristic part? Ash of bodies. So if they ask you what is the most characteristic lesion of rheumatic heart disease, you will say they are the ash of bodies. So what are ash of bodies? I think you all know. R, H, D, all the three alphabet things have which necrosis? So many times we have studied. All the three alphabet things are going to have fibrinoid necrosis. All the three alphabet things have fibrinoid necrosis. So ash of body kya hoga? In the center you will have fibrinoid necrosis and around it you will have cells. What are the cells that I'm talking about? Anishkau cells. I am talking about the Anishkau cells. So now how does Anishkau cell look like? Anishkau cell can, number one, like this. Look at this pencil like this. Like this, it's known as caterpillar. So ye dekho, Anishkau cell can look like this, zigzag, zigzag, aisa like a caterpillar. If I turn this caterpillar and show it to you like this, it's looking like a dot. In this dimension, it was looking like a caterpillar. In this dimension, it's going to look like a dot. So like this, you call it a caterpillar. Like this, you call it owli. So Anishkau cell is the same cell. When you look at it like this, it's known as caterpillar. When you look at it like this, it's known as owli. So here you have the caterpillar wala appearance. Here you have the dot, that is the owli appearance. But it's the same cell. So ultimately, what are ash of bodies made up of? In the center, they are made up of fibrinoid necrosis. And they are surrounded by what? They are surrounded by ash of cells. They can either look like a caterpillar or they can look like a owli. And where are they present? So please remember, ash of body are seen in all layers of the heart. But please note, all layers of the heart show you ash of bodies, matlab pericardium, myocardium, endocardium, sab mein. But maximum ash of bodies are gonna be seen in M for M. Maximum ash of bodies are seen in the myocardium. Always remember. Why am I emphasizing so much? Because I've told you, na, this is the most characteristic part of rheumatic heart disease. Everyone sorted? Rheumatic heart disease start to end, sab kuch ho gaya. What is the next one that I wanted you to know in a little more detail? And that was the one which showed you the big bulky bad vegetations. Ye dekho, the big bulky bad vegetations which were infected also. This was infective endocarditis. What is the criteria that you have for infective endocarditis? Duke's criteria, na? So do you want to quickly revise that also? What is the modified Duke's criteria that you have for infective endocarditis? Again, kuch major hoga, kuch minor hoga. Before that, let me tell you the mnemonic. The mnemonic is Beti is the most valuable person. Okay? Beti is the most valuable person. But why have I written it like this? Beti ka BE is going to be your major criteria. Your major criteria is BE. That is number one, the blood cultures should be positive and these should be two cultures. You don't rely on one culture. These have to be two cultures which are taken 12 hours apart. There are two blood cultures that are taken 12 hours apart. So that is B for blood culture. And second, heart problem hai na, to endocardial echo pe involvement hona chahiye. So what is Beti? B is for blood culture and E is for echo, is showing you that yeah, there is an endocardial involvement. After that, everything else becomes minor criteria. Beti the most valuable person. तो बेटी का TI क्या है? अब infection है, तो fever तो होगा, temperature. Immunological criteria. Immunological criteria has two very important pictures. Roth spots and Osler's nodes. So these are the Osler's nodes. These are the Osler nodes. Please note, osler nodes are something that you see as subcutaneous nodules. And are they painless or painful? You say, ma'am, rheumatic heart disease also had subcutaneous nodules. Wahan to painless tha. Yahan pe osler is ouch. Osler is going to be ouch. These are painful. These are painful subcutaneous nodules. How do you differentiate between subcutaneous nodules of RHD versus subcutaneous nodules of infective endocarditis? RHD ka subcutaneous nodules were painless, whereas subcutaneous nodules of infective endocarditis are oslers. Osler is ouch. It is painful. Okay, so osler nodes is one, and the second one is going to be, so these are ouch wala is how you will always remember, hai na? Roth spots is R for R. These are retinal involvement. This is retinal emboli. This is going to be retinal emboli. So beti ka ho gaya temperature and immunological. What is most valuable person? Most valuable person mein M is for microbiological criteria. Microbiology mein the organisms should be there. Vascular phenomena. Vascular phenomena is known as Janeway lesion. What is Janeway lesion? These are rashes that you see on the palms and the sole. Janeway lesions are going to be seen. Janeway lesions are going to be seen on the palms and the soles. So those are the Janeway lesions that you all have to know. So beti most valuable bus person is left, which is the easiest one. There could be some predisposing factor, like maybe how did the person get the infection? Maybe he's an IV drug abuser. He's injected himself with the infection. So please remember the most common valve otherwise is mitral valve. Mitral valve matlab which side of the heart? Left side of the heart, right? However, if someone is an IV drug abuser, if you're dealing with an IV drug abuser, then the most common valve is going to be the right-sided valve. Any logic behind it? Tell me, IV drug abuser, intravenous, where is he injecting all the infection? In his venous blood. Venous blood goes to which side of the heart? Tell me, if this is the heart, venous blood will go to which side of the heart? Of course, the right side of the heart. So infection kahan aa raha hai? Infection is coming to the right side of the heart. So every time they ask you what is the most common cause of infective or what is the most common valve of infective endocarditis, you will say mitral valve. Rheumatic ka bhi mitral valve tha, iska bhi mitral valve hai. But if they say it's an IV drug abuser, then of course venous blood will come to right side of the valve. So right-sided valves will be more commonly affected. So what is beti most valuable person? B and E is blood culture and echo. T and I is temperature and your immunological criteria like Roth spots and Osler's node. Most valuable person is microbiological criteria, vascular phenomena like Janeway lesions, and some predisposing factors. So either you're gonna have all the 5 minor, yeah, let's start from major for that matter. Either you have 2 major, right? If you have only 1 major, then you'll have to compensate with 3 minor because minor criteria zyada the na. And if you have no major criteria, then all your 5 minor criteria should be there. So simple. I'll go back over here. Either you have these 2 major criteria and you are like, okay, I'm sorted. Dono major criteria hai, I'm sorted. If you have only one of these major criteria, then you'll have to compensate it with at least 3 of these minor criteria. And if you have no major criteria, then you will have to pick up all the 5 minor criteria. That is how you do the diagnosis of infective endocarditis modified Duke's criteria. And that wraps up all of your carditis story. Good. Now we're left with just 2 topics of the heart. So let's start with the next topic, and that is cardiomyopathy. Now when I'm talking about the cardiomyopathies, that's a list that I'm gonna cover, but I will finish this list in exactly 2 slides. Yeah, I promise. And you'll see how that happens. First is dilated cardiomyopathy. The name only tells me that something is going to get dilated. So when I say dilated, to kya dilate hoga? You will say, ma'am, dilated means that all the 4 chambers are going to get dilated. That's the concept. All the 4 chambers are dilated. Why are they dilated? You'll say, pata nahi. Means most common cause, pata nahi. Idiopathic. The most common cause is idiopathic. But when the cause is known, then the cause is alcoholism. So either they will, if idiopathic is written in the option, you will say best answer, safest answer to pick up idiopathic. But when idiopathic is not there, when the cause has to be delineated, alcoholism. And which is the genetic problem that they will want to ask you? Titin gene mutation. Yaad rakh lo. Idiopathic hoga, ya fir alcohol or Titin gene mutation. And what do you see microscopically? I'll enlarge this picture. There is something known as ninja star nucleus. How I have learned is that by drinking alcohol, everyone starts feeling that they are are like ninjas, right? After drinking alcohol. तो जो alcohol वाला cardiomyopathy है, alcohol and titin gene mutation वाला cardiomyopathy है. So remember, once you drink alcohol, there are two things you always, there's that comes into your mind. After drinking alcohol, number one, you feel I am a ninja star. And second, you always feel Titan एक watch brand है ना, you always feel this is my time, या अपना time आएगा kind of a feeling you have when you drink alcohol. So alcohol and Titan, and you feel all big and dilated and pumped up with a lot of ego, and you feel like ninjas. So ये पूरा story comes under dilated cardiomyopathy. Had alcohol, you feel अपना time आ गया है, that is Titan वाला time. You feel like ninjas and you feel big and bloated with ego and big and bloated with a lot of pride after drinking alcohol. That is dilated cardiomyopathy. You can have a look at the ninja star nucleus on a higher power. Ninja star nucleus, very, very important. The only picture on the internet, the only photo of ninja star that you're going to get in the exam, so mug it up as it is. Coming back, this was dilated cardiomyopathy when all the 4 chambers were dilating. Now I'm going to tell you something called Takotsubo cardiomyopathy, in which there is only left ventricle dilation. Only one ventricle ends up getting dilated. What is it known as? It is known as the broken heart syndrome. It's a cardiomyopathy that happens after those tiny little heartbreaks. But no one can have it, because heartbreaks nowadays, thanks to online dating platforms, heartbreaks are happening every day and night. So this has to be some major stress. So they will not give you something like a breakup. They will give you something like a family dispute, property dispute, someone losing her husband or some major loss in the family. That kind of an emotional stress will be given, because we all know that emotional stress, always everyone note that emotional stress is increase of what in the body. Emotional stress means there's going to be a lot of catecholamines in the body that are going to come up. Lots of catecholamines, and it's these catecholamines which are going to result in this left ventricle dilation. So have a look at this picture. ये देखो, ये था normal left ventricle. This is a normal left ventricle, and can you see what has happened? It has become like a round pot. Why am I saying the left ventricle has become like a round pot? Pot matlab Takotsubo. You know, Takotsubo is a pot in Japan. In Japan, Takotsubo is known as you can see it's caught an octopus na. So Japan mein jo Takotsubo hota hai, that is an octopus catching pot. They trap octopus in it. So your left ventricle starts looking like a Takotsubo. That is why they called it Takotsubo cardiomyopathy. So you've understood both the names. Why do we call it Takotsubo? Because your left ventricle starts looking like a Takotsubo octopus wala pot. And why do you call it broken heart syndrome? Because it is to do with a lot of emotional stress and catecholamines. So the difference is that in dilated cardiomyopathy, all the 4 chambers were getting dilated, whereas in Takotsubo, only one chamber is dilated, and that is the left ventricle. Moving on to the next slide. I told you the entire cardiomyopathy is in 2 slides. So ये last slide है. There is something called hypertrophic cardiomyopathy. So hypertrophy or hypertrophic cardiomyopathy. Why does it happen? How have you written it? HCM. Can you rearrange it and call it MHC? So the mutation and the inheritance, it's an autosomal dominant disorder, which is gonna be the MHC mutation. So simple na, when I say HCM, I say ulta kar do, that is gonna be MHC mutation. So there's going to be hypertrophy. Hypertrophy of what? There is going to be hypertrophy of the interventricular septum. Hypertrophy of which part? Interventricular septum. So remember, how is the heart going to look like? The heart is going to look like this. Grossly, because this interventricular septum has become so big and mota and hypertrophied, this part of the heart becomes very narrow. Left ventricle itna patla sa, banana shaped heart. That is what you see. So grossly, what you guys notice is the very famous banana shaped heart that you see. And what do you see microscopically? Mess. All the fibers are going left, right, helter-skelter appearance. Ye photo dekho. All the fibers are going left, right, oblique, diagonal, horizontal, vertical. So that is known as the helter-skelter appearance. So remember, on hypertrophic cardiomyopathy, we see the banana-shaped heart, and microscopically, we see all the fibers going left and right, and that is the helter-skelter appearance. So how is my patient going to present? This patient is going to be a sudden death. Sudden death in young athlete. Remember, the most common cause of sudden death in young athlete is going to be hypertrophic cardiomyopathy, because the body cannot pump that much blood. Young athlete, someone who's running a marathon or playing basketball or playing cricket or football, some kind of sporty marathon history would be there, and then they would say that the person has suddenly collapsed on the basketball field or the any other sporty field, and that is when you suspect hypertrophic. So ये 5 points ना ऐसे रट्टा लगा लो. Hypertrophic cardiomyopathy is an autosomal dominant condition with beta MHC mutation. It is hypertrophy of what? Interventricular septum. Grossly, heart looks like banana shaped. Microscopically, it is helter-skelter. Clinically, it is sudden death in young athlete. Khatam. Now let's move on to the next one. Arrhythmogenic. Patient is going to have arrhythmias. Right ventricular, so right ventricle will get affected. Cardiomyopathy. So arrhythmogenic right ventricular cardiomyopathy. Please note, only the right ventricle is affected. So if you look over here, ये है हमारा left ventricle, which is fine, and then this is the right ventricle, which is not fine because the right ventricle is looking very, very yellow. The right ventricle is looking very, very yellow. So basically, it's having a lot of fat. I can see the same over here. White color ka, the right ventricle is having a lot of fat. That is what you see in arrhythmogenic right ventricular cardiomyopathy. You know, it is associated with a syndrome. There is something known as the Naxos syndrome, which has plakoglobin problem. I'll tell you what that syndrome is. ध्यान से देखो. What did I teach you right now? Right now I said arrhythmogenic right ventricular cardiomyopathy in which there is involvement of right ventricle, and right ventricle में yellow fat आ गया. If I club that with a child having woolly hair, and I club that with someone having a problem in the hands and the soles, palms and, or in other words I say palms and soles na, to palmoplantar. Palms and soles के लिए I will say palmoplantar keratosis. Keratosis means very, very thick, lot of keratin. The palms and hands and feet are very, very thick. In तीनों का combination. There's a problem in the right ventricle. There is problem in the child with woolly hair. There is problem in the hands and the feet, and together this situation is known as the Naxos syndrome, and Naxos syndrome is a problem in the plakoglobin defect. That is the question that you get on arrhythmogenic right ventricular cardiomyopathy. Coming to the last cardiomyopathy, and that is the very famous restrictive cardiomyopathy. So please note, restriction, the body is or the heart is getting restricted. When I'm saying restrictive, so you'll say, ma'am, restrictive to what? See, I'm asking you, what are the two things someone can stop you from doing? Either someone can stop you from working, or someone can stop you from relaxing. So just imagine a story. You go to your house after your semester exams or your prof or your NEET or FMG, and you go back to your house. What do you want to do? You just want to chill, relax, eat, sleep and enjoy life, right? But there is some really unwanted, irritating relative who has come into your house and who's constantly asking you questions like, when will your exam be conducted? When are you going to get married? What are you doing in college? All of those irritating questions that person is asking you. Will you be able to relax? Nahi na? So simple. As when someone is sitting in your house, relaxation to nahi hoga. That is what has happened in the heart. Someone has gone and sat in the heart, for example, amyloid or any other thing, maybe some cancer, maybe some storage disorder, anything going and sitting in the heart, and relaxation ka problem ho jayega. Diastolic dysfunction is going to be there. That is a question. So question 1, what is the most common cause of restrictive cardiomyopathy? It is going to be amyloidosis. And what kind of problem happens? Systole or diastole? Heart can't relax properly. Like you won't be able to relax if some unwanted irritating relative has come. Same way, this unwanted irritating amyloid has come, heart can't relax. So diastole mein problem hoga. That is what you need to know about restrictive cardiomyopathy. I hope everyone's okay with this, because we have wrapped up all of our important cardiomyopathies that you had to know for the exam, with one controversy that I'm going to take up now. What do you see for hemochromatosis? This is a medicine question. Hemochromatosis, iron overload. Which cardiomyopathy does it show you? It can show you dilated cardiomyopathy and restrictive cardiomyopathy, but dilated cardiomyopathy is more common. So please remember, DCM more common than RCM. Very, very important point when it comes to medicine. Mug it up as it is. Can show you both, but DCM more common. Cardiomyopathies are done, and we move on to one quick question and then we'll go on to the next topic. A 19-year-old basketball player suddenly collapses on the court. I think I've got my answer. Young athlete, sudden collapse. Still, the cardiac monitor shows ventricular tachycardia, then ventricular fibrillation. He's successfully resuscitated. The patient's history, so he is successfully resuscitated. He survived. Collapse hua tha, but he survived. Okay. The patient's history tells you that the father died at the age of 38. 38 is no age to die. So fathers also died very young. There is a family history present, as I can see. The boy's echocardiogram revealed a thickened wall with a small slit-like chamber, maybe banana-shaped heart. Interventricular septum is markedly thickened. I can see that there is hypertrophy of the interventricular septum, and 5 years later the patient expires. 19 pe hua tha, 24 ki age pe he has died. This is a sudden death, young athlete. And on examination, the image is shown. You can see this helter-skelter, idhar-udhar fibers are going. This is a classical case of hypertrophic cardiomyopathy. There is no 1% doubt also in this. The clinical, the echo findings, the gross, the microscopy, everything is fitting into it. And it is an autosomal dominant situation. So that is why the father also died at a very young age of 38 years. Yes, sounds well. We are done with this. And now we are going to go back and study the last 2 slides of cardiac system, and that is the cardiac tumors. So now we are going to start with the cardiac tumors, just 2 slides about it that you have to know. If someone asks you what is the most common cardiac malignancy, do you guys know it's actually metastasis? Metastasis means that it is arising not from the heart, it is coming to the heart. Breast cancer, lung cancer, something coming to the heart is important. That is the most common. But when you ask me about primary cardiac tumors, tumors arising in the heart, I have divided them into 2 age groups, adults and children. First, let me finish off children. Children ka heart is simple, na? Adults ka heart is complicated. We complicate life. We complicate our heart matters. Children ka heart is simple. So that means the benign tumor in children is rhabdomyoma, and the malignant one is just ahead of it, rhabdomyosarcoma. Simple. So children mein to there is no problem. In children, it is going to be benign tumor is rhabdomyoma and malignant is going to be rhabdomyosarcoma. Myoma, myosarcoma. Simple. Adults mein, the benign tumor is myxoma, but the malignant tumor as we go forward, that is not myxosarcoma. That is different. Adults ka alag chalega na, adults ka thoda complicated hai. So the malignant tumor is going to be angiosarcoma. So dekho, bachon ka I told you na, bachon ka heart is sorted. Rhabdomyoma, rhabdomyosarcoma, khatam. Adults ka heart is complicated. Benign tumor is myxoma, malignant tumor is angiosarcoma. Finally, coming to the last one, primary cardiac valve tumor. I've added valve, mitral valve, aortic valve. Valve mein kya hota hai? Valve mein there is a tumor known as PFE, papillary fibroelastoma. Papillary fibroelastoma, and you can see because we've used the word papillary, it looks like this. Have you seen this character a lot in one of those cartoons? SpongeBob SquarePants mein hota tha na, ye cartoon character basically sea anemone. This looks like a sea anemone. It is a sea anemone type of a tumor because it's got papillary fronds na, that is why it looks like one of these sea anemones, aisa papillary. So remember which is the heart tumor which looks like a sea anemone, and that is papillary fibroelastoma that occurs in cardiac valves. Out of these, the ones that you need to know in detail are Mister. Dono benign wala. Mister is benign of adults and rhabdomyoma benign of children. So benign, Mister I have got over here. Why am I calling it Mister again and again? Because I'm going to draw the heart and I'm going to write Mister like this. M and R. Where have I written M? M upar likha hai, bada, upar. So this is going to happen in adults. And rhabdomyoma R niche, chota. So that is going to happen in children. Then where have I written myxoma? Myxoma I have written in the left atria. So the chamber is going to be left atrium. Rhabdomyoma I have written niche. So the chamber is going to be left ventricle. For the cells, remember, myxoma shows you lipidic cells. Myxoma shows you can see this jelly-like myxoid tumor, and it shows you as a lamba. Lipidic cells are going to be seen, and you can see this jelly-like, this jelly kind of a tumor. Matlab myxo matlab jelly na. So you can see lipidic cells, whereas rhabdomyoma shows you the very famous spider cells. You have to know this. Spider cells are seen in this entire slide. The most important question is this. Spider cells are seen in rhabdomyoma and spider cells are pass positive. ये जो खाली खाली spider spaces है ना, spider web spaces, they are pass positive. Lastly, coming to their syndrome. So please remember, myxoma is associated with Carney complex. Myxoma is associated with Carney complex. Carney complex is a very important mutation, that is PRKAR mutation. So Carney is complex, whereas this again, rhabdomyoma का तो सब कुछ important है. It is associated with tuberous sclerosis. Rhabdomyoma, tuberous sclerosis. Repeating, पहले Mr. लिखा, M ऊपर तो adults, R नीचे तो children. M is ऊपर तो left atria, R is नीचे तो left ventricle. Myxoma shows you lipidic cells, rhabdomyoma shows you spider cells. So spider cells in sclerosis, spider cells are seen in tuberous sclerosis. Myxoma is lipidic cells which you see in the Carney's complex. And that wraps up all of your cardiac tumors and all of the rapid review of the cardiac chapter that I have to give all of you. Now let's begin with the next chapter, and that is the respiratory or the lung pathology. Now we've kept a target of 40 minutes in which I'm going to cover up one of the most important topics and images, starting from obstructive lung diseases, restrictive lung diseases, especially the pneumoconiosis. Then we're going to go on to the most important lung tumors. Talking about lung pathology, the first set of diseases are OLDs, obstructive lung diseases. These include COPDs, asthma, and bronchiectasis. So always in medicine we learn it as what? We always say that is stuck in a cab. Stuck in a cab obstruction. Obstruction means stuck, na? So stuck in a cab means COPD, asthma, and bronchiectasis. These are the ones which are going to be obstructive lung diseases. Starting with COPD, we all know there are two COPDs that we always focus on. One is going to be emphysema and the other is chronic bronchitis. Let's quickly look at their images and their types and definitions that you have. So starting with emphysema, and whether I talk about either of them, one common thing that you will see in both is that both of them are heavily associated with smoking. The association with smoking is very strong. So starting with the first one, and that is emphysema. Can you fill in the blanks for me? Can you tell me that emphysema is a permanent damage to which airways? Distal to which? So this is a question that has come in the previous years, and they say that this is distal to the terminal bronchioles. This is distal to the terminal bronchioles. So now you'll ask me, distal to the terminal bronchioles. After the terminal bronchioles, the damage will occur. So what is there after the terminal bronchioles? After the terminal bronchioles, we have RDS. All of you have to remember RDS. What is RDS? RDS stands for respiratory bronchiole, number one. DNS stand for alveolar duct, D for alveolar duct, and S for alveolar sac. So please remember, respiratory bronchiole, alveolar duct, and alveolar sac, these are the three things which are going to get damaged. So question dhyan se padna. If they say that what is getting damaged, you will say RDS is getting damaged. Or if they ask you after which stage is it getting damaged, distal to which step is it getting damaged, so distal to the terminal bronchioles, we have RDS, and RDS are getting damaged. And you can see the damage. Can you see? None of the walls are joined. Ideally the walls should have been all joined like this. Now none of the walls are joined. They are all broken. So that is referred to as floating septa. You can see a lot of floating septa that are present over there. So how many types of emphysema do we have? The most common type of emphysema that we see clinically, dekho, C. C is going to remind you, C is what? Common. So if I ask you which is the most common emphysema clinically, the most common emphysema clinically is centri SNR, and centri sounds like S, na? So this is the one that is associated with smokers. So smokers are going to show this. So how simple, na? S wala centri SNR wala sound, S for smokers, and common clinically. So now smokers mein jo centri SNR emphysema hoga, that involves the upper lobe. How do I learn this? Smoke is hot air. Hot air is always going to go up, na? So smokers mein it's going to involve the upper lobe. Now moving on to the anatomy. What part, when I say centri SNR, what do I mean? So I have made an acinus over here. All of you will ask me that, okay, there are everywhere you use the word acinus. Acinus kya hota hai? Acinus is nothing but RDS. Please note, RDS is nothing but acinus, means respiratory bronchiole, alveolar duct, alveolar sac. So what have I drawn over here? I have made a respiratory bronchiole, and over here I made alveolar duct and sac. This is a respiratory bronchiole, duct and sac. Respiratory respiratory bronchiole, duct and sac, RB and duct and sac. When I'm saying that I'm dealing with centri-acinar emphysema, only the central part is gone. Central part basically means that the respiratory bronchiole is gone. The alveolar duct and sac are okay. What did I say? The respiratory bronchiole, please repeating once again, the respiratory bronchiole is going to get affected. That is the one that is damaged. Central mein wahan central part is affected. And so now when we go into the details of this, we realize that the respiratory bronchiole is damaged, which you can very well see over here that there is a damage that has occurred, whereas the alveolar duct and sac is spared. But on the other hand, when I use the word pan-acinar, pan means everything is gone. This entire thing, everything, RDS, everything is totally damaged. So I say that when all is damaged, that is referred to as pan-acinar emphysema. Coming to the next one, distal. Distal means only distal, end wala part is damaged. End wala part means that only the alveolar duct and sac are damaged. The respiratory bronchiole is perfectly fine. What did I say? The alveolar duct and sac are damaged, but the respiratory bronchiole is totally spared. Whereas when I talk about irregular, no one can predict. It is totally irregular, so no one is going to ask you this also. But let me tell you, the most common histologically is irregular emphysema. And now you will see what is the difference. You will ask me that the most common clinically means maximum patients who come to you, most common clinically centri-acinar emphysema, but the most common type that you see on autopsies is irregular emphysema. So read the question carefully. Most common clinically, C for C, centri-acinar emphysema. Most common histologically is going to be the irregular emphysema. Now you will ask me which is the one that you see in smokers. So S for S, smokers mein dikhega centri-acinar, and which is the one that you see in alpha-1 antitrypsin deficiency? That is pan-acinar, most common in alpha-1 antitrypsin deficiency, and that tends to involve the lower lobe. That is why I gave you mnemonics when we started this table. Ke pehle mnemonic rat lo. That is, what is smoke? Smoke is upper, smoke is hot air. Hot air always goes up. So smokers mein upper lobe is affected, and smokers have that S wala sound, so it is the centri-acinar emphysema that is going to occur. So that everything opposite. For alpha-1 antitrypsin, now the lower lobe is affected. Now it is pan-acinar emphysema that is going to occur. So let me take a very, very quick test over here. If I say that only the central part, central matlab respiratory bronchiole is damaged, central part is damaged, you will say central part damage hua hai, that is centri-acinar. If I say everywhere you are seeing this dot, everything has gotten damaged, all of it has damaged, that is pan-acinar. And if I say only the distal part, only the distal, you can see now right next to the covering, only the distal part has been damaged, the alveoli have been damaged, this means it is distal acinar. So which of these is capable of causing pneumothorax? Socho, which of these is capable? You will say, ma'am, over here, when these alveoli, because they are so big, they will dilate, they will rupture. So this is the one which is capable of causing spontaneous pneumothorax. That is a question that you get in medicine also, spontaneous pneumothorax. I hope the difference between the three pictures is clear. If only the central part is damaged, centri-acinar. If everything is pan-acinar. If only the distal part is damaged, that is distal acinar. Yes, so emphysema seems to be done, and I hope all of you remember that these are the people who are referred to as pink puffers. They take in a lot of air. The oxygen entry is totally fine. The problem is that they cannot give out CO2. Taking in inhalation, that is okay, but to exhale out, to push out the CO2, that is problematic. That is why, you know, air is entering, okay, but air is not going out. So you will say that initially if the lungs were chota, now air is entering, the lungs are going to become very, very big, and when the lungs will become big, what will they do? They will push the diaphragm down. So what do you see radiologically? Radiologically we see the flattening of the diaphragm. Radiologically we see flattening of diaphragm. This was about the emphysema. Now coming to the next one, chronic bronchitis. First you need to know the definition. There are three parts to that definition that I want all of you to know. First part is that patients have productive cough. Productive cough means cough with sputum. What is the duration? It should be for 3 months in 2 consecutive years. Back to back 2 years, mein 3 months is what is the duration of this cough, and all other causes have been ruled out, because in our country, cough with sputum could be TB, it could be cancer, it could be bronchiectasis, it could be asthma, it could be so many things. So all other causes need to be ruled out, then you will come to the diagnosis of chronic bronchitis. Why does this happen? I've already told you that all these situations are associated with smoking. So whenever there is a lot of smoking, don't you feel there will be a lot of mucus production? And smoking is irritant, right? You will inhale, it will irritate, a lot of mucus production will occur. Mucus production means there is an increased risk of infections. What is the infection which is most commonly seen with COPD patients? You've learned this way back in your microbiology section, and that is H. influenza. Has an increased risk of infection that you notice. Coming to the next one. Because there is an increase in the mucus production, there is an increase in something known as the Reed index. So tell me one thing, mucus to बढ़ रहा है. Everyone is saying, okay, you are smoking, so your mucus production, but who is increasing? Who is making that mucus? So what is Reed index? Reed index is defined as the ratio of the thickness of which glands? Who is making mucus? Submucosal glands. Obviously, they are going to increase. So if I ask you, what is the ratio of the submucosal glands divided by the overall thickness of the wall? What do you think? Is the numerator going to increase over here? Of course, there is going to be increase in the glands. Why? Because itna mucus has to be produced. So when the numerator will increase, automatically the index will also increase. So please remember, the normal Reed index is 0.4. The normal Reed index is 0.4, whereas in a case of chronic bronchitis, it is more. So first thing, because of a lot of mucus, there is a lot of infection, especially H. influenza. Because of a lot of mucus, there is an increase in Reed index. Normal Reed index is 0.4. And please remember, these patients are also said to be associated with cor pulmonale. Now, there's a very important controversy in medicine that you have. What is cor pulmonale? I hope everyone knows. It is pulmonary hypertension with right-sided heart failure. So they ask you, is chronic bronchitis associated with cor pulmonale? Yes. And they also ask you, is emphysema also associated with cor pulmonale? Yes. Please remember, both of them can be associated with cor pulmonale. Both of them can be associated with cor pulmonale. However, the more common with chronic bronchitis. That is what you have to learn in medicine over here. So COPD comes to an end. What do we move on to next? We move on to asthma. I'm not going to tell you asthma is what hypersensitivity, because that's the most cliche question I can ask you, but still bol dete hain. It is type 1 hypersensitivity, it is allergy, right? They ask you that if you get to examine the sputum of a patient of asthma, sputum microscopic examination, what are you gonna see? And I think we all know the very famous 3 C's: Charcot-Leyden crystal, Seriola body, Kirschmann spirals. So let's get going. What is Charcot-Leyden crystal? You can very well see a nice needle-shaped crystal over here. Charcot-Leyden crystal is made up of galactin 10. From where do we get galactin 10? Galactin 10 is coming from the eosinophils. So please remember, Charcot-Leyden crystal comes from eosinophils, galactin 10. Next, they ask you, what are these Seriola bodies? I can see these round cell clusters. So please remember, Seriola bodies are going to be nothing but epithelial cell clusters. They are going to be epithelial cell clusters. And finally, what do you see? You see this spiral thing. What is this spiral? The name is only spiral, Kirschmann spiral. And who is making this spiral? It is made up of mucus. So repeating, what are the 3 C's that you see? Very, very important. The 3 C's of asthma. Firstly, jo Charcot-Leyden crystal hai, that is galactin 10. Seriola bodies are epithelial cell, and Kirschmann spiral that you see over here, that is made up of mucus. But you'll say all of this is seen where? All of this is seen when the person spits out the sputum. The sputum is coughed out. That is when you see it. What do you see in the lungs? In the lungs, you see something known as airway remodeling. Please remember, this is a previous year question. Asthma shows you airway remodeling. What is airway remodeling? Everything is increasing. You say, is the mucosa increasing? Yes, mucosa mein basement membrane, eosinophils, muscle layer, submucosa. Basically, everything is increasing. Why? Because asthma is not a simple one-time thing. Na? Asthma, people suffer with asthma for years and years and a lifetime. So imagine so many attacks of asthma will occur, your lungs will change. Remodeling to hoga na. When I keep pressurizing you, obviously you are going to change after a certain period of time. So because asthma happens so many times, so many attacks of asthma occur, so there is an airway remodeling that is going to occur. Everything that you notice is going to increase. Mucosa, submucosa, all of that increases, and that wraps up your discussion of asthma. So COPD is done, asthma is done. Now we move on to the third one, and that is bronchiectasis. It's so simple. The definition is in front of you. As soon as I use the word ectasia, ectasia means dilation, right? And dilation of what? Of the bronchi. So simply I'll say dilation of the bronchi and the bronchioles. There are lots and lots of reasons for it, but there are two reasons or two set of reasons which I want to delineate. Why are the bronchi and the bronchioles getting dilated? Either there is going to be a genetic cause, which is the very, very famous Carter-Jenner syndrome. It is the Carter-Jenner syndrome, or it is going to be the acquired causes. In acquired causes, either it could be a case of some obstruction, some foreign body has gotten obstructed, or it could be a bacterial infection, for example, sepsis. Obviously, the question that you're going to get is always Carter-Jenner syndrome. Can you quickly give me a 3-sentence thing about what is Carter-Jenner syndrome? Carter-Jenner syndrome is the dynein defect of cilia. It is a dynein defect of cilia. So the cilia of the lung stop working. And why is there a ciliary defect? Because dynein is an actual thing that is undergoing defect. Carter-Jenner syndrome is going to come across as a beautiful triad. Tiny little cute triad I'm making. Obviously, the first part of the triad is in front of you, and that is bronchiectasis. That is the lungs stop having a proper function. Similarly, sinuses. These patients also have sinusitis, and these patients also have situs inversus. So please remember, that is bronchiectasis to pata hi hai. Then there is SNS, there is sinusitis, and there is situs inversus. What is situs inversus? Left ka right, right ka left. Things which are supposed to be on the right, invert. Ab wo left pe hoga. Things which are supposed to be on the left, they are going to be on the right. Example, the heart is supposed to be on the left, but now it's going to be deviated towards the right. So dextrocardia. So left, right, right, left problem, that is going to be situs inversus. So this is the beautiful, cute little triad that we made for Carter-Jenner syndrome. But there is one thing which is not in the triad but is very, very important. This is also associated with male-female infertility. It is also associated with male-female infertility. As I'm saying, it's not a part of the triad, but it's important as a finding to know. So remember, this Carter-Jenner, this very cute little summary of Carter-Jenner that I have made for all of you, it will definitely help you in the long run in pediatrics. You will learn the triad, you will learn separately male-female infertility. The problem is in the dynein arm of the cilia. Done with bronchiectasis, but why not we do the the microscopy, or you can say the gross and the radiology also. Please note that bronchiectasis, can you see that there are dilated bronchiectasia? तो bronchiectasis में dilasis दिख रहा है. कहाँ दिख रहा है? Is it seen in the upper lobe or the lower lobe? It is very commonly seen in the lower lobe, because one of the most common locations is the LLL, left lower lobe is very common. What are you going to do? You're going to do an X-ray and a CT scan. In fact, the investigation is definitely going to be the HRCT that you have over here. And I assume that everyone can see the very, very famous tram track appearance. The tram track appearance is very famous when you have the bronchiectasis involved. On that note, the OLDs are done. Now I come to the RLDs. OLD में क्या था? CAB. COPD, asthma, bronchiectasis. Most important is asthma ka wo 3C pictures that you have to know. Now I come to restrictive lung diseases, in which I'm gonna cover sarcoidosis and pneumoconiosis. So let's get going. For sarcoidosis, I've tried to make 2 slides so that everything can get summed up over there. This is a classical case of sarcoidosis that I have in front of you. So what is sarcoidosis? If I ask you what is the reason for sarcoidosis, and you will put a question mark in front of it, because the exact reason is not known. It is something immunological, but what is not known. ठीक है, तो nothing that I have to learn. And it is, as you can see, I've made a full human body. It is a head to toe disorder. It is a multiple organ disorder, multi-system disorder. बहुत कुछ होगा. But if I ask you which is the most common organ affected, the most common organ affected is going to be the lungs. After the lungs, there are going to be big lymph nodes that you see, and those are going to be the potato nodes. Remember, firstly, the most common is going to be this lungs. After that, the nodes are affected. affected, which are said to be the potato nodes. Apart from that, you will be able to see a lot of other organs. Like for example, there is involvement of eyes, that is uveitis. There is involvement of a lot of glands, that is Miculix disease can occur. Then you will also see there could be involvement of many organs. For example, this could also result in hepatitis. Hepatitis usually a study viral hepatitis, hepatitis A, B, C. ये non-infectious है. This has nothing to do with infection. Sarcoidosis is not an infectious, so non-infectious hepatitis can occur. Then I can see some skin lesions also. What are these skin lesions? Skin lesions are erythema nodosum, that becomes a component of the Lofgren syndrome. So please remember, Lofgren syndrome में N आता है ना. So N basically stands for erythema nodosum. N stands for erythema nodosum, and that is what you see as a part of the sarcoidosis also. What else can you see as a part of sarcoidosis over here? You will say that okay ma'am, sarcoidosis में fever भी होता है. ठीक है, fever is also there. Can you see the presence of joint pain? Yes, ouch. This is going to be ouch for joint pain. I'm telling you the full form of Lofgren, what I have made. L is what? You also see a lot of lymph node, lymphadenopathy. So ho gaya Lofgren. What is Lofgren? We are gonna have L for lymphadenopathy, O for ouch, that is joint pain, F for fever, N for erythema nodosum, and what is this GR? Because do I know that sarcoidosis shows me a lot of granulomas? Exactly. And that is exactly what I'm going to teach you next. Sarcoidosis shows me granulomas. Very important. So please note guys, lymphadenopathy, joint pain, fever, granuloma, erythema nodosum. This is a component. I've tried to make a mnemonic out of Lofgren syndrome, which will help you recall it better. And this is what you're going to see over here. But before I go on, ye granuloma se related, there was a lot of things. So what are all the microscopic findings? Which kind of granuloma is most common? So दोनों होता है. Caseating is also there, non-caseating is also there. Non-caseating granuloma is the most common type of granuloma that you see. Apart from that, there is also something known as a naked granuloma. Naked, when I say something is naked, matlab clothing is not there. So ideally every granuloma has a cloth. What is that cloth known as? That cloth is known as the lymphocytic collar. But when that so every granuloma is surrounded by lymphocytes. Now I'm saying the lymphocytes are not there. Because the lymphocytes are not there, the granuloma has become naked. Then there are two bodies. I can see asteroid and Schaumann body. Asteroid body is in front of you. It's a complete star. There is nothing more for me to explain. What is Schaumann body? So yaad rakhna, S for Schaumann, which you see in sarcoidosis, and C for calcium. Schaumann body is this, which you can see is made up of calcium. Very important. Very important. So there are two bodies, asteroid bodies and Schaumann bodies. Asteroid bodies look asteroid star, and Schaumann bodies are round calcium wala bodies. So whatever did you see, Lofgren was also a type of sarcoidosis only. So I've told you granuloma bhi dikhega. Now I can also notice that for the diagnosis, there is a skin test that they are doing. What is the skin test that they are doing? There is a Weem test that can be done for sarcoidosis. So this needle is indicating a skin test. Then I can do a couple of blood tests also, and listen to this very carefully. These people have three very important blood tests that you have to mug up. Firstly, you will be finding out that their calcium levels are elevated. Second, you will be finding out angiotensin converting enzyme, ACE enzyme levels are elevated. And third, you will find out the CD4 upon CD8 ratio is also elevated. So three things in the blood which are elevated: the CCC, Ca for calcium, CD4 by 8, and Ce, that is ACE enzymes. Calcium, ACE enzymes, and CD4 CD8 ratio, all of these three are elevated in the blood. That is why I told you for sarcoidosis, if you know this one slide, you know uveitis, Miculix, lung involvement hai, potato nodes hai, hepatitis hai, erythema nodosum, which is a part of the Lofgren syndrome. You know there is a skin test known as the Weem test. You know there are three blood tests which will come positive. Then in terms of granuloma, you know non-caseating and naked granuloma. Two bodies are there. One is asteroid, one is Schaumann body. See, life becomes so simple. Sarcoidosis is done. But before I proceed, where else do you see asteroid bodies? Asteroid matlab star. Star is going to be seen in nesses. Star is seen one place in pathology, one place in microbiology. So please remember, how will I differentiate? In sarcoidosis granuloma होता है. Granuloma मतलब there is a giant cell. In sarcoidosis there is a giant cell. The star is seen inside the giant cell. There is an intracellular star that I'll see. Whereas in sporotrichosis, the star is out in the open. There is an extracellular star that I'll see. And how will you not get confused? Sporotrichosis is the Rose Gardner's disease. Sporotrichosis is Rose Gardner. Rose Gardner तो बाहर घूमेगा ना. Rose Gardner is not going to sit inside this room. Rose Gardner is going to roam around in the rose field. So Rose Gardner is roaming outside. Therefore, the star is also roaming outside. Whereas in sarcoidosis, the star is going to be sitting inside the cells. Okay? Both of them show you asteroid body. Very important. So sarcoidosis is sorted for us. The next restrictive lung disease that we go on to is the pneumoconiosis. Again, I've tried to make one table out of it so that two tables mein all your pneumoconiosis are in one place. So pneumoconiosis basically means I'm going to deal with all occupation related stuff. And the most common pneumoconiosis that we have is of course silicosis. Silicosis pe question aayega. Not only will it be that it is the most common pneumoconiosis, they will also give you a question that which industry. So they will give you something to do with the glass industry that will be mentioned. So remember, when silica matlab when this goes into the lungs, in lungs it causes nodules. Lungs mein there is something known as nodular fibrosis, and lymph node is a very important finding that you have in radiology. In lymph node we see eggshell calcification. In lymph node we see eggshell calcification. You know, people who have silicosis, this is the most important question. They are at an increased risk of TB, jo anyone in our country is anyway at a risk of, but they are at an increased risk of lung cancer, and that is why it is so worrisome. Remember, they are at an increased risk of TB as well as cancer. This is the expected question for silicosis. It can affect the lungs causing fibrosis. It can affect the lymph node causing eggshell calcification. Moving on to the next one. Now someone working in the coal industry. Coal matlab someone working in that black lungs wala coal industry. So coal industry mein kaam karne se there are 3 steps in which the patient will proceed. First, he will just have black lungs, nothing else, no symptoms at all, just black lungs. Remember that advertisement before every Bollywood movie, Mukesh ke saath wala advertisement where they show you black lungs and they squeeze the lungs, wo wala black lungs. Black lungs are known as anthracosis. After 5-10 years of working in the industry, he develops simple coal workers pneumoconiosis. So socho, coal, smoke. Coal is nothing but smoke. So if I say there is some emphysema that is going to occur over here, which emphysema will you label it? Sentry SNR, smoking ke saath kaun sa? Sentry or pan? So you'll say smoking, S wala sound. So we will write sentry SNR emphysema that will occur over here. Finally, after 5-10 more years, patient has complicated coal workers pneumoconiosis, which basically results in fibrosis. So what is the sequel? What is the series of events? First, patient only has black lungs, then he has simple, then complicated. Simple mein sentry SNR emphysema and complicated mein fibrosis. Do you know someone who has coal workers pneumoconiosis with rheumatoid arthritis is labeled as Kaplan syndrome. Remember, Kaplan syndrome is coal workers pneumoconiosis plus rheumatoid arthritis. Very important. So basically a joint involvement comes. Coming to the next one, examiner's favorite, asbestosis. Let me tell you one thing. All the pneumoconiosis, write this point, all the pneumoconiosis that you have are going to involve which lobe of the lung? They involve the upper lobe of the lung. But when I'm talking about asbestosis, from today onwards you can learn it as basestosis, because asbestosis is going to affect the lower lobe of the lung. Okay? All others, so whether it is silica, coal or anything else, it will all affect the upper lobe, but asbestosis will involve the base of the lung, that is lower lobe. So first and foremost, what are the different forms of asbestosis and what industries am I talking about? So asbestosis is number one known as something known as amphibole. Amphibole का दूसरा नाम is crocodolite. Crocodolite form, and there is another form that we have that is known as the serpentine or chrysolite. That is the serpentine or chrysolite. So how am I going to learn which form is which name? Remember that amphibian kaun hota hai? Go back to your school days, you used to study amphibian is someone who is basically going to live in land and in water. So don't we believe that crocodile can live in land and in water, na? So amphibian and crocodolite is the same, and serpentine serpentine and chrysolite is going to be the same. Okay, serpentine and chrysolite is same. So amphibian and crocodile in one place and serpentine and chrysolite in one place. These are the two forms of asbestos that are known. So when someone starts inhaling asbestos, what do I mean by inhaling asbestos? That person is working in which industry? The shipyard industry. So please remember, there will always be a history of working in the shipyard industry. There could also be working of cement industry. So shipyard industry हो सकता है, cement industry हो सकता है. Please note, one fine day he's not going to wake up with problems. First condition that we'll have is a pleural plaque. The first condition is pleural plaque. After that, the second thing formed is going to be a pleural nodule. Then a proper nodule will form. And do you know what you'll see inside the nodule? Inside the nodule, we will see these asbestos or ferruginous bodies. Inside this nodule, we are going to see asbestos or ferruginous bodies. And please let me tell you, why do you call them ferruginous? Because you can see the stain that has been used over here. Why have I used this blue color stain? Prussian blue or pearl stain. What is this a stain of? This is a stain for iron. So basically there is iron deposition. देखो, ये वाला is just asbestos, brown color का asbestos fiber. What does my body do? Around this asbestos, your body says, I will deposit iron. I will deposit iron. And has it made, so you can see it's become like a dumbbell. It's become like a dumbbell shaped body. Exactly what they ask you in the paper, that asbestos bodies are what in shape? They are dumbbell shaped bodies that you notice. Repeating once again, when the person is working in either a shipyard industry or a cement industry was the NEET PG 2023 question. So please remember, the first thing that the patient develops is a pleural plaque. After the pleural plaque, the person is next going to develop a nodule. Nodule के अंदर you will see these asbestos body, because asbestos is fiber है, and ferruginous you understand because you have deposited iron around it. You have deposited iron around it. So pearls or Prussian blue will be positive. And finally in the end, patient lands up with cancers. Now the question comes in the exam is that what are the two cancers that you see in asbestosis? Which is the most common cancer and which is the most specific cancer? So if I say common cancer, common is दोनों lungs का है. This is also of the lung, common वाला, and the specific is also going to be of the lungs. So please remember, the common one is going to be adenocarcinoma lung. Very easy to learn, na? Common is carcinoma and specific is going to be mesothelioma. Specific is going to be mesothelioma. So repeating, common wala is carcinoma, specific wala mesothelioma. So that is what I've written again. Number one, you have pleural plaque, then you have pleural nodule. Pleural nodule mein you're going to see those dumbbell shaped asbestos body, and finally from pleural nodule you're going to see cancers. If you want a quick recap, the most common carcinoma is going to be adenocarcinoma, and the most specific cancer that you're going to have is going to be mesothelioma. The same information I have told you way back in the neoplasia chapter also. Okay, so these three are done for us. Now we move on to the simple jaldi se 1-1 wala pneumoconiosis. What is byssinosis? Byssinosis means someone is exposed to cotton or organic dust. Cotton or organic dust. What is bagasosis? Bagasosis basically means sugarcane dust. There is exposure to sugarcane dust. Berylliosis, of course, beryllium, I mean there is no doubt about it. There is exposure to beryllium, and barytosis mein there is exposure to barium. But out of these you get a question on berylliosis. What is the question on berylliosis? These patients show you non-caseating granulomas. Berylliosis shows you non-caseating granulomas. That's a question of the previous year. Coming to stenosis. Stenosis matlab tin wala, tin ya lead wala exposure. And sidro means when someone is working in the iron industry. So their names are pretty much characteristic. The only two names which need evidence is byssinosis and bagasosis. Byssinosis is to do with the very famous cotton dust, and bagasosis is to do with sugarcane dust. Sorted with the pneumoconiosis. Basically, we are also sorted with all the restrictive lung diseases. So the next part of this that we are left with is definitely going to be the very famous lung tumors. Now, before I start, the most famous common lung tumor. Basically, in lung tumors, I am going to start with the benign lung tumors. The most common benign lung tumor is going to be pulmonary hamartoma. And I want to remind you of one mnemonic. I used to tell you that it is going to be hamara tissue, And then I used to tell you that हमारा ही popcorn है, हमारा ही coins है. I have paid for the money. I have paid the money, so I will get to eat the popcorn. I will get to eat the popcorn and I will get to take the tissue paper. So I have paid the money, I get the popcorn, I get the tissue paper. Means when I'm talking about pulmonary hamartoma, hamara tissue. So my tissue, there is increase in cartilage. Cartilage is normal tissue of the lungs. So more tissue, normal tissue is increasing. Hamara coins is basically telling me that it's showing you a coin lesion. It is showing you a coin lesion, and hamara popcorn is telling me that it's showing you popcorn calcification. That is what you need to know about hamartoma. Repeating once again, hamartoma is going to be hamara tissue, so cartilage increases, hamara money, that is coin lesion, and hamara popcorn, that is popcorn calcification. That is this hamara tumor, that is pulmonary hamartoma, which is the most common benign lung tumor that you have. Lung tumors में benign हो गया, so I think I can move on to the cancers now. The most common lung malignancy, what is that? Most common? None of these. Most common is metastasis. Remember, even for cardiac, the most common was metastasis. For here also, the most common is metastasis. But now forget metastasis. What are the 4 cancers of the lungs? Squamous cell carcinoma, adenocarcinoma, small cell carcinoma, large cell carcinoma. Now, out of these, the most common that you have is going to be adenocarcinoma, and that is going to be more common in males as well as females. But that's the gender and the preponderance you have to know. Adenocarcinoma is the most common in males as well as females. Which are the ones which are associated with smoking? So smoking के साथ SSS वाले tumor. Smoking, squamous, small. Smoking, squamous, small. Which of them are associated with some kind of location? Location where they will ask you either it is center or it is peripheral. Center or peripheral. So remember the way I write central. Central में वो S वाला sound है ना? तो squamous and small are going to be central. SS. Squamous, small, central. Whereas adenocarcinoma and large cell are going to be peripheral. How simple? Adenocarcinoma and large cell is going to be peripheral. Now let's so abhi this table is so simple. Adeno is most common in every gender. That is done. Smoking ke liye SSS, smoking, squamous and small cell carcinoma. Central also SSS, that is squamous and small are central, squamous and small are smokers. Simple. Repeating, squamous and small are smokers and squamous and small are central. Coming to now the genetics and the precancerous conditions. Yes, please remember, squamous cell carcinoma is going to show you mutation in P53. P53 matlab policeman. Policeman shows you a mutation. Adenocarcinoma is going to show you EGFR1. It is going to show you the KRAS mutation, and it is going to show you the ALK mutation. And all of these I have taught you. There is nothing new that I'm telling you. All of this information is from way back your neoplasia chapter, where I told you A for adenocarcinoma, A for ALK, KRAS, and EGFR1 is also A alphabet. So remember, EGFR1, KRAS, and ALK are adenocarcinoma. Talking about small cell. Now remember, chromosome. This is something very important. I've got it as it is from Robbins. I wanted to tell you. So remember, loss of chromosome 3p is seen. Chota sa cancer, chota sa chromosome, third chromosome. Loss of chromosome 3p is seen in almost all the small cell cancers. And the way you write small cell lung cancer, LLL, the way you write small cell lung cancer, it has a lot of L's, na? So remember, L-mic amplification is going to be noted. L-mic amplification. So I think we are done with it. Squamous cell carcinoma ke liye policeman, adenocarcinoma ke liye all AA and 1-1 things, and small cell ke liye chota sa chromosome is problematic, that is chromosome 3, and so many L's are coming, so L-mic amplification will occur. Do they all have precancerous conditions? Yes, please remember, for squamous cell carcinoma, all of them are associated with some or the other precancerous condition, but where you're going to get a question is this: what is the precancerous condition seen with adenocarcinoma? That is known as AIS. What is AIS? Have a look at this picture. AIS stands for adenocarcinoma in situ. So that is only telling me that, oh yes, this is pre-cancer stage. Earlier it was said as BAC, bronchoalveolar carcinoma. Earlier it was said as back, that is bronchoalveolar carcinoma, but then they said ye to carcinoma word, students will think it is a cancer. It is not a cancer, ye to pre-cancer hai. So they said this word is not nice, we will call it adenocarcinoma in situ, because that will tell me that this is a precursor lesion, this is a pre-cancerous lesion. And you know what does it show you? It shows you the lepidic pattern, or also known as the butterfly on fence appearance. It is known as the lepidic pattern or the butterfly on fence appearance. So have a look at this. What is butterfly on fence? That all the butterflies are sitting on one place. You can see all the cancer cells are sitting on one place. That is why all the pre-cancer cells, I can say that they're sitting on one place, because if they would have been like proper cancer will go everywhere in the body. It will show you invasion. That is not happening over here. They are innocently sitting at one place. That is what you see in butterfly or fence appearance or the lepidic pattern. That is why I'm calling it a precursor lesion. Please note, all of them have a precursor lesion, but adenocarcinoma in situ and uska jo lepidic pattern is very famous for adenocarcinoma, right? Okay, now on that note, the next thing that I want to ask all of you, are there images, their markers and paraneoplastic syndromes? So let's start. When I'm talking about the famous squamous cell carcinoma, everyone knows how to identify squamous cell carcinomas, and that is by the formation of these keratin pearls. I think everyone knows P for pearls, P for is how we're going to learn. So PP yaad karna start karo. I'll tell you how. What are the IHC markers? The IHC markers will be P40 and P63, out of which P40 is the best. So please remember, keratin pearls wala jo tumor hai, that is squamous cell carcinoma, has P40 and P63 as the immunohistochemistry markers. What is going to be the paraneoplastic syndrome? The paraneoplastic syndrome is hypercalcemia. This was the NEET PG 2023 and the FMG 2023 question. Very important. This is hypercalcemia, means, now I will tell you a lot of paraneoplastic syndromes. You will get confused. So from today onwards, when you say squamous cell carcinoma, call squamous cell carcinoma as, write squamous cell carcinoma as this spelling. So instead of writing Q, remember squamous, K, calcium wala sound hai. Squamous cell carcinoma is going to have calcium. So remember, squamous cell carcinoma will remind you of calcium, hypercalcemia. And because it shows you keratin pearls, it will have all the PP wala markers. Am I clear with squamous cell? Can we go on to adenocarcinoma? How do I identify adenocarcinoma? With the presence of these, adeno word always means glands. So I'm going to see glands. What are the IHC markers? So adeno mein sab kuch A se chalta hai, right? So there is going to be napsin A. Napsin A, and or if A is not there, then number 1 has to be there. 1A is the first alphabet, na? So you're going to have MUC 1, you're going to have TTF 1. So all the 1 and AA alphabets are going to come in adenocarcinoma. What is the paraneoplastic syndrome? I'll first tell you and then I'll tell you the mnemonic, because I have told you the mnemonic way back in your neoplasia chapter. There is something known as migratory thrombophlebitis. I hope you all remember from surgery that migratory thrombophlebitis is known as the Trosius phenomena. So migratory, something is roaming around. You know, your mothers and everyone in your colony says, the one kid in the colony who is always roaming around, they said, this person is avara. Avara means always roaming around. So when something is roaming around, it's avara. Remember, adeno is avara. Adenocarcinoma is avara. It is always and always going to roam around. It's going to show you migratory thrombophlebitis. Migratory means it's going to roam around. Thrombus and inflammation. So now let's decode it only. Thrombo matlab thrombus. Itis matlab inflammation. Phlebo means veins. So it's going to migrate from one vein to another, from one vein to another. It's roaming around. So adenocarcinoma is avara. So this is done. Now we move on to the last one, small cell. Oh my God, it was small cell, but it's gone so big. Look at this slide. That is why I always say small cell sounds small, but it's got maximum things. It's chota packet, bada dhamaka. So it sounds like small, but it's got the maximum things under it. So look at the microscopy. First and foremost, I can see a lot of blue color blood vessels. blue blood vessels. These are referred to as the Azzopardi effect. Blue blood vessels are noted. Next, what I see is the very famous salt and pepper chromatin. What is salt and pepper? White and black, salt and pepper. So when I zoom in, I will definitely see that the nuclei are not totally blue. There are some white dots in them. If you look very carefully, there are some white dots in them. So that is the salt and pepper chromatin that you're gonna see. And at the end of the day, please note that small cell carcinoma is a neuroendocrine tumor. So when you will look at it under the electron microscope, ये black and white वाला becomes electron microscope ना. So when you're going to look at it under the electron microscope, you are going to see these neurosecretory granules. You are going to see these neurosecretory granules. That is what is important. So remember and repeat once again. What all do you see in small cell carcinoma? Blue blood vessels known as Azzopardi, salt and pepper chromatin, and electron microscopy shows me neuroendocrine tumor hai, to neurosecretory granules will be seen. So now I say if it is a neuroendocrine tumor, the markers should also be neuroendocrine. What are the neuroendocrine markers that we have? We have in, synaptophysin, chromogranin, bombesin. Repeating in, and then we have three short forms: CD56, CD57, NSE. Repeating, any neuroendocrine tumor of the body will have the same profile, guys. Please remember, synaptophysin, chromogranin, bombesin, CD56, 57, NSE. All of them are going to have, all the neuroendocrine tumors have in, and three short forms. Finally, paraneoplastic. Again, this was just chota packet, na, but everywhere bada dhamaka. Look at the number of paraneoplastic syndromes. This is the tumor which has maximum paraneoplastic syndromes, and look at them: SIADH, Cushing's disease, Lambert-Eaton. Out of them, the most common that is there known in literature out of all these is SIADH. So I realized that small cell was only naam se small. Look at the microscopic features, they are maximum. Look at the immunohistochemistry list, it's maximum. Look at the paraneoplastic syndromes, it's maximum. So if I put up a blank slide and I say out of squamous cell, out of adenocarcinoma, out of small cell carcinoma, and large cell the most neglected person tha, hai na? Can you quickly tell me the IHC markers and the paraneoplastic syndrome? Not writing them again, it's for your very quick review. Squamous cell had that K sound, so calcium was increased, right? So we'll start with maybe the paraneoplastic syndrome first, right? The calcium is increased. Adeno was avara, so it had the famous migratory thrombophlebitis. Small cell, maximum paraneoplastic syndromes, whether it is SIADH, whether it is Cushing's disease, whether it is Lambert-Eaton, all these are going to be there. Talking about the IHC markers, squamous cell had pearls, na? So PP wale markers, P40, P63. Adeno had all AA things. It had napsin A, it had MUC1 and AA and 1 thing, MUC1, TTF1. And small cell had small nahi, it had the longest list. In, synaptophysin, chromogranin, bombesin, and then it had three short forms, that is CD56, CD57 and NSE. So these are the long lists. So what did you analyze overall? Sabse danger kaun sa sound kara? Sabse danger, of course, in the end sounded this small cell only. It was small, but it was most dangerous. So they ask you which is the most aggressive cancer out of all of these. The most aggressive cancer out of all of these is gonna be the small cell carcinoma. Very important point for all of you to know. Before I end, there is one last tumor that I want all of you to practice with me, and that is the tumor that is a pleural tumor, means a tumor that is arising from the pleura, and that is mesothelioma. I could have just taught you mesothelioma in 2 minutes and walked off, but why am I comparing mesothelioma with an adenocarcinoma? What is common? Because both of them are having after the same exposure. Remember, asbestosis could cause adenocarcinoma commonly and mesothelioma specifically. So both of them are having the same, the history of asbestosis will come in both. So please remember, for mesothelioma, either this black and white microscopy will be able to save you, or for mesothelioma, there is a marker known as calretinin. Calretinin positivity is what you see for mesothelioma. Very, very important. And how does the electron microscopy help you? So, dekho, adenocarcinoma. No means no. So, are you going to see any branching? No, you see no branching. Non-branching microvilli. Over here, you are going to see chota, no branching. Chota microvilli, non-branching microvilli. Whereas talking about mesothelioma, you are going to see long microvilli. You are going to see long microvilli, as you can notice over here. So repeating once again, adenocarcinoma mein there is no branching microvilli. Whereas mesothelioma mein there is going to be long branching. There is going to be long branching microvilli. Sorted? So either they will ask you the difference on the basis of electron microscopy, or they will ask you a quick marker for mesothelioma. So asking you one quick question, which of these is used as a marker for mesothelioma? How nice. Right now only I taught you, that is the question that you're going to get. It is going to be calretinine as a marker. Answer one more question. What is the marker for small cell carcinoma of the lung? So remember in, yahan to sab in hai, to sirf in. Remember, you don't have to learn only the mnemonic. What was in? Synaptophysin, not in the list. Bombicin, not in the list. Chromogranin, in the list. And that is your answer. So thoda sa dhyan do. Don't just learn mnemonics, also learn the full form of those mnemonics, right? Thank you so much, because with this we have wrapped up our entire discussion of the lung tumors and the lung chapter in general. I hope you've been able to rapidly go through this. Now let's begin with the next part of the rapid revision, and that's the GI tract. Now under the GI tract, or the GI intestinal pathology, we basically need to know that first we'll start off with the esophagus, then we go and discuss the stomach etiologies, and then we go ahead with the intestine, of which you all know that tumors in general in this entire chapter remain very important. So esophageal tumors, stomach tumors, and intestinal tumors and polyps, all the more important. So let's get going first with the layers of the GI tract. So what are the different layers that we have? Please note that amongst this there is 4 layers that we all know since our first year. There is mucosa, there is submucosa, there is muscularis propria, and there is serosa. So here you can see the mucosal, the epithelium. Then next what you have is going to be the submucosa. What you have next is the proper muscle, and lastly on the outside you have the serosa. Please note that the gallbladder does not have a submucosa. That's a very important question that you guys have in surgery. And the esophagus does not have the serosa. So these are 2 exceptions that you have to know. Next, you also need to know that the pacemaker cells of the GIT are the cells of Cajal. So the pacemaker cells are going to be the cells of Cajal, and later on I'll be telling you there is a tumor that arises from the cells of Cajal, and that is known as GIST. We'll talk about that in a while. Let's first start with the different diseases that come under the esophagus, and I'm first going to pick up achalasia cardia. Now when I'm talking about achalasia cardia, we all know that it's a condition in which the esophagus is contracted. So I think I've told you the diagnosis beforehand. The esophagus is contracted over here, and that is achalasia cardia, which means that there is nothing to open up the esophagus. The relaxers are lost. There is loss of VIP and nitric oxide. What are VIP and nitric oxide? They usually relax the esophagus. They are usually going to relax the esophagus, and now they are not there, means there's no one to relax the esophagus. So the esophagus is constantly contracted. Tell me guys, who contracts the esophagus? So contraction is always mediated by acetylcholine, and acetylcholine is working well, but the relaxers, that is nitric oxide and VIP, which had to open up the esophagus, they are not there. So there's no one to open it up. So acetylcholine works and the esophagus remains in that manner. So now what is it because of? Of course, there are 2 very important reasons. Number 1 being, I don't know, that is idiopathic. But when they ask you the reason, they are very fond of an infection, that is Trypanosoma cruzi. I hope everyone remembers that Trypanosoma cruzi causes something known as Chagas disease. So they will always ask you a question regarding Trypanosoma cruzi or Chagas disease with achalasia cardia. So how does the patient present? Of course, just imagine this person is consuming some food or some water. So is there going to be difficulty in having that food or water? Of course, yes. So there is going to be dysphagia that the patient will present with. But please note, and I hope you all remember, dysphagia is more to liquids than solids. Because where do you see the other way around? Please remember, when we are talking about dysphagia, if they say dysphagia is more to solids than to liquids, what in surgery are you expecting? You are expecting it to be probably a case of esophageal cancer. Out here, dysphagia is more to solids than to liquids, but in achalasia cardia, dysphagia is more to liquids than to solids. Now, how do you do the diagnosis? You have the barium study in front of you. I'll write it again for you. I've shown it to you. On a barium study, we see the very, very famous bird beak appearance. You can see that over here. We'll erase this and have a look at it. Can you all see this bird beak appearance? Yes. So that is what you see on a barium study. How do you do the treatment? So one part of the treatment is going to be medicine. You can give an injection of botulinum toxin. Why are we wanting to give that injection? Because botulinum toxin mainly decreases the activity of acetylcholine. I know that these kids or these things are lost, okay? These chota nitric oxide VIP are lost. I can't do anything about the loss. But I know that the contraction is happening because of acetylcholine. So let me just act on this acetylcholine. If I reduce this acetylcholine, the contraction will reduce and this esophagus will automatically open up. So how do I reduce the acetylcholine? By giving an injection of botulinum toxin. If that doesn't work, then we can go ahead and do a surgery that is known as Heller's myotomy, which of course you studied well in your surgical aspect. So that wraps up achalasia cardia for us. Let's move on to the next. There is another condition of the esophagus known as alcohol-induced lacerations. Now the word only tells you that the esophagus is going to have tears or laceration, and all of that is going to be because of alcohol. So they are of two types. One is a Mallory-Weiss tear and the other is the Boerhaave tears. So how are you going to divide Mallory-Weiss? I've written a mnemonic for you. The mnemonic of Mallory is Mallory. So let me, split that mnemonic for you. What does M stand for? M stands for mucosal tear. What kind of tears are these? These are all mucosal tears, means all superficial. What are they because of? You can see the next two alphabets, AL for alcohol. So of course they are all alcohol induced. AL for alcohol. So M for mucosal, AL for alcohol. What is for low? Low is going to tell you two things. Please note that these tend to be longitudinal ulcers. Longitudinal matlab they are going to be along the long axis. And one more thing with low that you have to know is that they are below the gastroesophageal junction, right? So please note they are below the gastroesophageal junction and they are longitudinal. That is what you stand for, low out here. So let me draw a tentative diagram for you. If this, for example, is the gastroesophageal junction, these are longitudinal, aisa lamba and below the junction. Everyone's okay with it? So let's do a repeat. When I'm talking about Mallory-Weiss tear, M is going to be mucosal, AL is going to be alcohol, low is going to be longitudinal and below the gastroesophageal junction. So if it's a superficial tear, and that means, and if it's only below the junction, everything about Boerhaave will be opposite. It is going to be a full thickness tear. There is going to be full thickness. All the layers are gone. All the layers are going to be involved. And is it going to be below? Now this time it's going to be above. It is 2.5 centimeters usually above the gastroesophageal junction. So everything that you know about Mallory-Weiss, you're going to make it opposite for Boerhaave. So how do these patients present? Imagine someone's esophagus above or below. Esophagus is tearing. There's going to be bleeding, of course. So in medicine, we study something known as the Mackler's triad. There's going to be bleeding and that blood will obviously come out in the vomitus. Common sense. If there's going to be bleeding, so I can either way say there is hematemesis. There is hematemesis, blood is going to come out in the vomiting, and that tear is associated with a lot of chest pain. So this is basically a kind of a painful hematemesis. That is what we describe it in medicine. There is painful hematemesis. Also think something logically, not for Mallory-Weiss, but for Boerhaave at least think that when all the layers are going to get damaged, obviously there is going to be a case of subcutaneous emphysema because the esophagus has in a way ruptured. All the layers, as you look at the esophagus, you shall realize that all the layers have gone. So obviously there is subcutaneous emphysema, and that can be heard on auscultation as the Hammond's crunch, which is a very, very important auscultatory finding that you study in medicine. So this together is known as the Mackler's triad. Remember, there is painful hematemesis and there is going to be the Hammond's crunch, which is subcutaneous emphysema. Now, having discussed this, we move on to the next aspect or the next disease, and that is going to be Barrett's esophagus. This I've already taught you way back in the first chapter because I hope you all remember that Barrett's esophagus was a type of a metaplasia, isn't it? So we have already studied it and we're going to quickly revise it, recall it once more. Now, when I'm talking about Barrett's esophagus, please note that if it's a metaplasia, one thing has to change into the other. So what is changing to what? Normal epithelium of the esophagus is squamous epithelium, and whenever the patient suffers from gastroesophageal reflux disease, that changes to intestinal columnar epithelium. Please note, intestinal. What is so special about intestinal columnar epithelium? It has the very, very famous goblet cell. So when you shall zoom into this picture, you all shall be able to identify these khali, empty cells. These are all known as goblet cells. But are they actually empty? Of course not. They contain something very, very significant. And what is that thing? Now when I tried that, okay, oh, these were the goblet cells, but why are they coming out to be blue? Because I have put a stain called Alcian blue. Why? Alcian blue stains which mucin? It stains acidic mucin. So please note that goblet cells contain acidic mucin, and acidic mucin is going to be positive for Alcian blue, A for A. Acidic mucin is going to be positive for Alcian blue, and that is why you see the color over here coming across as blue. Okay, so this is about Barrett's esophagus. Why did we study it? They ask you what kind of a metaplasia is it. Remember, it is an intestinal metaplasia. This is the epithelium that is forming. So why are we studying this? Because is this precancerous? Of course, this is going to be precancerous, and there is a high risk of which cancer? Glands hai to kaun sa wala cancer? There is going to be a risk of adenocarcinoma. So exactly what I'm going to start off with next. I'm going to start with cancers of the esophagus, and under cancers of the esophagus, of course, we have two types. Either we have squamous cell carcinoma or we have adenocarcinoma. When I'm talking about squamous cell carcinoma, I'll start off with the risk factors first. Firstly, whenever I talk about squamous cell carcinoma, I have divided into A, B, C, D, E. I've tried to make a kind of a mnemonic out of it. So alcohol ke saath smoking goes hand in hand. Then we have B for hot beverages. C for celiac disease. Celiac disease is ideally a disease of what? It is ideally a disease of the intestine, but it has a risk of squamous cell carcinoma of esophagus. D is going to be for drugs and any radiation. E for epidermolysis bullosa. So ABCD is done. Repeating: alcohol and smoking, hot beverages, celiac disease, drugs, epidermolysis bullosa, and then we have three miscellaneous things. Miscellaneous but very important. So सबसे पहले we have the human papilloma virus. I think this everyone knows that when I'm talking about the human papilloma virus, anywhere that you have squamous epithelium, HPV causes squamous cell carcinoma, be it the epithelium of the cervix or the penile cancer or anal canal cancer or oral cavity cancer, everywhere squamous epithelium is present, HPV will cause squamous cell carcinoma. Then there is something called Tylosis palmaris et plantaris. If you break the word, it's not at all difficult. Palmaris and plantaris means hands and soles, palms and soles. Tylosis means thickening. So what all you are having over here, this is going to be thickening of the palms and the soles. That is Tylosis palmaris et plantaris. This also has a risk of squamous cell carcinoma of the esophagus. Next, we have something known as PV syndrome, the Plummer-Vinson syndrome. This is a fancy name after scientists. PV syndrome is fine, but the other name is really going to help me. And the other name is going to be sideropenic dysphagia. When we say sideropenic dysphagia, break the word. Sidero matlab iron, penic matlab deficiency. So first thing that these patients have is iron deficiency anemia. Next, why are they having dysphagia? Why is there difficulty in eating? Because the next finding that they have is esophageal webs. And finally, what is the third finding that you see, which you just need to mug up? That is going to be atrophic glossitis. So actually, Plummer-Vinson syndrome is going to come across as this triad. Patient is going to have sideropenic matlab iron deficiency anemia, dysphagia means esophageal webs. The third thing you will have to learn is atrophic glossitis, and because there's a problem in esophagus, so later on kya hoga? Later on there is a risk of squamous cell carcinoma of the esophagus. How do you identify any squamous cell carcinoma in the body? There's a trick of identifying each and every squamous cell carcinoma in the body, and that is with the help of keratin pearls. Any SCC in the body, you shall identify that with the help of keratin pearls, right? This was about squamous cell. What about adenocarcinoma? Adenocarcinoma, I've just told you, one of the most important risk factors, that is going to be Barrett's esophagus. Right now we studied the metaplasia wala condition, and I know for a fact that whenever I'll read the word adeno, there is going to be what? There is going to be glandular formation. So I can very well see that yes, there are lots and lots of glands that I see under the microscope. Now just as a quick review, if I divide the esophagus like this into, say I'll just divide it into lower 1/3 and then the rest of it. Adenocarcinoma is more common in the lower 1/3 of the esophagus, because over here only gastroesophageal reflux disease occurs. Now over here only Barrett's occurs. So if Barrett's esophagus will occur here, adenocarcinoma will also occur here. Whereas in the upper part, there is going to be most commonly squamous cell carcinoma. So this is something that they can ask you in the exam. The lower part has more chances of adeno, upper part has more chances of squamous. But if they ask you overall, which is the most common cancer overall, not only in the upper part, but also if they ask you overall, they've not given you upper, lower, they've just asked you, what is the most common cancer of the esophagus? Put your common sense. Esophagus ka normal epithelium is squamous epithelium. So the cancer that will arise will be squamous cell carcinoma. Sorted with everyone. Esophageal cancer is also done. We are sorted with the esophageal part of it. Now let's begin with the next part, and that is the stomach pathology. The first disease that we are going to cover under it is known as the Menetrier's disease, and I always say that if you know these 5 points about Menetrier's disease, you are sorted. So first and foremost, as we call it Menetriers, and as the name tells you men, this is more commonly seen in men. It is more commonly seen in males. Next, what is the cause of it? It is because of an increase of a mediator called TGF-alpha. Now let me tell you something about this. TGF-alpha, many students get confused in the exam whether it is TNF-alpha, TGF-beta, so on. So I'll give you a very simple way of learning it. TGF-alpha is G and A. That will always remind you of gastric. Okay, so TGF-alpha is what you have to select because this is a stomach pathology. It is a gastric pathology. Moving on to the next, what is the clinical part that you have over here? Please note that this ends up being a protein losing enteropathy, which means that when I'm saying protein losing, there are going to be intermittent attacks of edema that the patient will have. There is going to be intermittent attacks of edema that the patient is going to have. Yes. Moving on to the next. How does the stomach look grossly? You can see that very much in front of you. It's looking like the brain. It's looking like a walnut, isn't it? So the stomach ends up having the cerebriform rugae. So I have learnt it in a simple way that when you start seeing the stomach, which has started looking almost like the brain, you know you are dealing with the Menetrier's disease. And you can see these big folds which are cerebriform rugae. So if I look at the same thing under the microscope, which cells are going to be more? There's an increase in the foveolar cells. This is a foveolar cell hyperplasia. So these 5 points, if you know about Menetrier's, you're sorted. Question 1, the gender, that is more common in men. Question 2, it is associated with TGF-alpha. Question 3, it is a protein losing enteropathy. Question 4, it is looking like the brain, so cerebriform rugae. And question 5, it is a foveolar cell hyperplasia. So that is what we have under Menetrier's. Let's move on to the next disorder in the stomach, and those are the very important, the 10-star questions, and that is stress ulcers. When I'm talking about stress, I'm not talking about the stress of just exams, NEET, FMG and INICT. I'm talking about genuine, real stress that the person can have. And not that your stress is not genuine, but it's like real bodily physical torture that a person can have in the form of burns or in the form of meningitis. So something that is going to play around with the blood supply of your body. So when I talk about curling ulcer, please note that curling ulcer is the ulcer that you see associated with burns. So I have learnt curling, burning. Okay, rhyming. Curling ulcer is associated with burns. So curling, burning. Whereas Cushing ulcer is associated with increase in intracranial tension. So again, there's a way of learning everything. So I say rhyming jao. So Cushing is tension. So tension, Cushing, rhyming. And curling is to do with burning. Next question. One of them is going to occur in the duodenum and the other one is going to occur in the stomach. So how am I going to decide on those? Please note, whichever has the S is going to occur in the stomach. So Cushing has the S that occurs in the stomach and curling then occurs in the duodenum. After that, please remember they ask you about which is superficial and which is deep. So curling ulcer is a superficial ulcer, whereas Cushing ulcer is going to be a deep ulcer. And how are we going to learn that? So remember, Cushing is pushing. Cushing is pushing very, very deep. So that is how we've learned this as well. So everywhere you have a mnemonic and it's going to not result in any confusion going forward. So what kind of stress I'm talking about? Either burns or some meningitis like intracranial tension increase. So remember, when we're talking about burns, burning patient is going to have curling ulcer. Intracranial tension patient is going to have Cushing ulcer. Then Cushing has S, so that occurs in the stomach. Curling occurs in the duodenum. And Cushing is going to be pushing, so that is the deep pushing ulcer. Sorted with stress ulcers, let's go on to the next topic of the stomach, and we have to talk about a bacteria in the stomach, and that is the Helicobacter pylori. So this bacteria is very, very important, and there is one enzyme property about this bacteria that you know from microbiology. It is a urease positive organism. So I've shown you the urease test. I hope you remember. The urease test being positive means it's going to give a pink color. When a pink color comes positive means we are dealing with the urease test. Now going forward, before I tell you the diseases, I hope you know what are the stains that you have for Helicobacter pylori. The most important question, there is something known as the Warthin-Starry silver stain. Warthin-Starry silver stain tells you that it is to do with something silver. Silver word matlab black, na? So always remember this rule, na? I've been telling you since day 100 and millions of times I've told you. So all the black color things that you're seeing, these become the Helicobacter pylori, Warthin-Starry silver stain. Other than that, there is also something known as the modified Giemsa stain which can be used, which is less important to know. Zyada important, which you'll get a question on, is WSSS, Warthin-Starry silver stain. And you know it is a urease positive organism. So now your question is that what are the two cancers in the human body that this can cause? Please note that Helicobacter pylori causes two cancers, and both of them are of course cancers of the stomach. One cancer is the most common cancer of the stomach, that is adenocarcinoma, and the other cancer is known as maltoma. So I'm going to teach you both of these first. We are going to first study adenocarcinoma, then we'll go on to the lymphoma, that is maltoma. Both of them are associated with Helicobacter pylori. So starting with this one, adenocarcinoma, first I'll ask you from surgery point of view, what are the risk factors? So you will realize that ultimately, ma'am, alcohol, smoking and hot beverages to cause everything, whether it is esophageal cancer, whether it is stomach cancer, or even going forward intestinal cancer. There is going to be always an involvement of alcohol, smoking and hot beverages. Next we have very important, stomach cancers are associated with smoked and salted food. You know, once upon a time, smoked and salted food was only something that was a part of the Japanese cuisine. So they used to say that it's only seen over there. In Japan it was endemic, but now that we've gone global and all types of food items are being consumed everywhere in the world, this means the gastric cancer is also now prevalent everywhere in the world. But yes, this has a very high association with pickled and smoked and salted foods. After that, I think this you already know that it is associated with H. pylori, exactly what I was telling you. Iske baad kya yaad karoge? You will learn A for adenocarcinoma is going to cause A, and A. That is, it is going to cause pernicious anemia. It is going to cause adenomatous, or it is going to be associated, I would say, with pernicious anemia, associated with adenomatous polyps and blood group A. So remember, adenocarcinoma is associated with pernicious anemia, adenomatous polyps and blood group A. So blood group to ratta lagana hai, that you've done. Blood group A, adenomatous polyps can cause adenocarcinoma, ho jayega yaad. What is pernicious anemia? I hope you all know pernicious anemia is the B12 deficiency that occurs. So now I want to tell you that forget pernicious anemia for a minute. Whenever cancer occurs for because of any other reason, alcohol, smoking, beverages, food, polyps, blood group, bacteria, whenever cancer occurs, please note that the most common site is going to be the antrum. Whenever gastric cancer occurs, the most common site is the antrum. But whenever gastric cancer occurs in pernicious anemia, the most common site becomes fundus. Repeating, if you are just asked what is the most common site of the gastric cancer, it is antrum, but the most common site of gastric cancer that you have in pernicious anemia, and that is going to be the fundus. Hope everyone's okay with this set of information. No concern, no queries. Yes. Now I'm going to tell you what are the different types of gastric adenocarcinoma, and I'm a pathologist, so obviously I will always give emphasis onto the microscopic type. So remember guys, there is a classification known as the Lawrence classification, which says that stomach cancer is of two types. Pehla to simple intestinal type. Intestinal means there are gonna be round glands, just intestine has, same intestinal type. You won't get many questions on this. What you'll get a question on is the other type. The other type is referred to as the diffuse gastric cancer. And before I get into the details, gastric cancer to pata hai, I want you to know what is the meaning of the word diffuse. I just want you to mug up one thing, that what is the problem in the genetics that happens over here, and that is referred to as loss of EK adherens. So please note that EK adherin, go back to your neoplasia chapter I have taught you over there, that EK adherin mein what is going to be there? EK adherin mein there are, what is EK adherin? I told you EK adherin is a glue, it's a fevicol. EK adherin tends to hold the cells together. Normally, that is what EK adherin does for all of us. I am saying that EK adherin is lost. Now, when EK adherin is lost, that basically means that this glue is gone. Look at this, the glue is gone. Now the cells are not going to be stuck together. They're all diffused. They're all separate. So I hope all of you remember that when I'm talking about loss of EK adherin, there are two tumors that can occur that you need to know. What are the two tumors, guys? One, remember ek mnemonic tha golu? I told you that EK adherin is like glue, and when the glue is lost, there are golu tumors that occur. So number one, the golu mein go is for gastric cancer. It is diffuse gastric cancer that it is going to cause. And what is go lu mein lu? That was invasive lobular carcinoma breast. Invasive lobular carcinoma breast is also what it causes. Go back to your neoplasia chapter. You made a beautiful table on these, on these genetics. We've done this over there. I hope you remember. So we had said when the glue is lost, the go lu tumors are gonna occur. Okay, so on that note, diffuse gastric cancer ka genetics I've done, but now I also need to look at the gross and the microscopy of the same cancer. So I'll make a flashcard over here. Diffuse gastric cancer genetically shows me loss of EK adherin, but at the same time, grossly if they ask you, it has the very famous linitis plastica. What is the meaning of linitis plastica? It basically means that there is a leather bottle appearance. Leather bottle jaisa yahan pe dikh raha hai. Like you see a leather bottle over here. What is the meaning? Have you guys ever seen a leather bottle? Leather bottle basically means that it's very rigid. It's very tough. You can't, like a plastic bottle, you can easily crush it, na? You can squeeze it, you can crush it. Leather bottle is very tough. You can't press it. Why? Because in this, the cancer is over here, guys. Look at this. The cancer is out here in the wall. The stomach becomes very tough like a leather bottle. You cannot squeeze that stomach. So please remember that in this stomach, there is a cancer that is present in the wall of the wall shows you the presence of the cancer, and thus it looks like a linitis plastica, leather bottle appearance. When you look at under the microscope, it is going to show you the very famous, that is the signet ring. Now let me quickly analyze what this signet ring is for all of you. So if you look at this, I've drawn a cell for you. Can you all see that the nucleus has been pushed at the periphery? Why is the blue color nucleus at the periphery? That's why ring jaisa na. Why is it at the periphery? Because someone else is sitting inside, and that someone else is nothing but mucin. That is what is a signet ring cell. So please note, in every cell you will realize that the nucleus has gone and sat at the periphery. Can you see the blue color nucleus is at the periphery like this over here? Why? Because someone else, mucin, is sitting. Let's look at some other cells. Everywhere you will see, yes, the nucleus is at periphery, nucleus is at periphery. So in each one of them, nucleus is pushed on the side because mucin is sitting there, and that is what you see in signet ring cells. And you see that in diffuse gastric cancer, but I will also ask you that where else do you see it? So signet ring cells are not only seen in diffuse gastric cancer, they are also seen in the same golu. Do you remember the same GOLU? So one was G for gastric cancer, LU was for invasive lobular carcinoma breast. And imagine if a gastric cancer goes to the ovary or a lobular cancer goes to the ovary, what do you call that cancer which is going to the ovary? Krukenberg tumor. Na? This means Krukenberg tumor is also going to show you. Any Krukenberg tumor of the ovary is also going to show you signet ring cells. So ultimately I realize whether they are talking about loss of E cadherin, there also my mnemonic is GOLU, gastric and lobular cancer. Whether they're asking about signet ring cells, there also my mnemonic is GOLU, the same gastric and lobular carcinoma. But remember, when both of them go to the ovary, what do you call them? Krukenberg. So obviously Krukenberg is also going to show you the same signet ring cells. Sorted with everyone? Easy, no confusion. Let's move forward, because this was all about what, guys? Gastric adenocarcinoma in terms of pathology. I want you to know a little bit of clinical also. How does this gastric adenocarcinoma spread? Very important part. Fancy names na examiner ka favorite. So when they ask you about this gastric adenocarcinoma, if it goes to the pouch of Douglas, the rectouterine pouch, the pouch of Douglas, what is that situation known as? Blummer's shelf. Please note shelf. Pouch of Douglas kahan hota hai? Pouch of Douglas is niche na, like rectouterine, the bottom of your body. It's a shelf of your body. It's the bottom shelf of your body. So bottom shelf matlab Blummer's shelf. ठीक है? So pouch of Douglas mein, if the gastric cancer goes, you call it Blummer's shelf. If it goes to the ovary, I just now told you anything going to the ovary is known as Krukenberg tumor. Simple. If it goes to the periumbilical region, and that is a very famous setting that you get, there's a nodule in the periumbilical region. You have to think of Sister Mary Joseph nodule. Sister Mary Joseph nodule is a very important periumbilical finding that you see over there. If it goes to the axillary lymph node, Irish axe, that is how we learn it, Irish axe. So axillary lymph node to Irish node hoga. And if it goes to the left supraclavicular lymph node, it is going to be the Virchow's node. This I've told you way back in your beginning also, that Rudolf Virchow, who's the father of modern pathology, gave you a lot of contributions. One of them was the left supraclavicular lymph node. Okay? So repeating, if it goes to the pouch of Douglas, it is Blummer's shelf. If it goes to the ovary, it is Krukenberg. Periumbilical is Sister Mary Joseph. Axillary is Irish axe, and left supraclavicular is the Virchow's node, and that is what you have for gastric adenocarcinoma. Remember, I told you this Helicobacter pylori, number 1 causes gastric adenocarcinoma, we have studied. Number 2, it causes a lymphoma, and that lymphoma is known as a maltoma. So they will now ask you that what are the different types, or what are the things that you have to know for a maltoma. Maltoma matlab lymphoma. Kaun sa wala lymphoma? It is MZL, marginal zone lymphoma. So I've already told you that which is the bacteria that is associated with marginal zone lymphoma. Maltoma or marginal zone lymphoma means the same. So with marginal zone lymphoma, you have something known as H. pylori. Same question I will ask you when I go to the hematology rapid review. Now talking about the genetics, the same question about marginal zone lymphoma I will ask you when we go over there also. Translocation 11 and 18 is what you see in MZL. But what I'm going to tell you, especially for the stomach over here, that when maltoma occurs in the stomach, you see something known as the very famous lymphoepithelial lesions. When we say lymphoepithelial lesion, some students and authors also call it as LELs. They might ask you, LEL is seen in which lymphoma? LEL is seen in which tumor? So lymphoepithelial lesion. So if you look at over here, very characteristically, we have nicely labeled it out here. You can see that there is, dekho, ab now tell me one thing, I have two words na, there is something called lympho and there is something called epithelium. So you will say, ma'am, you will see something called lympho wala part, epithelium wala part. Cancer kaun hai? When I'm saying it's a lymphoma, tell me, is the lympho part the cancer or the epithelium part the cancer? Common sense na, lymphoma mein lympho part is the cancer. So the troublesome, the naughty and the dangerous part is the lympho wala part. So can you see, ye jo ... lymphocytes hain, they are trying to invade into the epithelium. Yes, can you see that the lymphoma cells are invading the glands, and that is what you call as the epithelium. They are invading the glands, and by glands I basically mean epithelium. epithelium. So that is why you call it a lymphoepithelial lesion, because the lymphoma cells are the cancer cells. They're trying to destroy everything. And that is what you need to know about maltoma. So 3 stat questions. If they ask you which bacteria, it is H. pylori, translocation 1118, and microscopically lymphoepithelial lesion. So the 2 H. pylori related ones are done. Gastric adenocarcinoma done, maltoma done. So you will say, ma'am, 1 epithelial tumor done, carcinoma, 1 lymphoma also done. Kya reh gaya? No stromal tumor you've spoken about. That is not associated with H. pylori. That is totally different. So what am I going to talk about? The only stromal tumor that you have is going to be gastrointestinal stromal tumor, that is GIST. And way back on the first sentence of this chapter, I told you that the cell of origin of gastrointestinal stromal tumor is the cells of Cajal, the pacemaker cells. From them, the GIST is going to arise. So now what are the mutations? And this also you have studied again way back in your neoplasia chapter, that CD117 or c-KIT. Do you remember what were the tumors that were associated with CD117 or c-KIT? So if I can make a list and remind you, I'm not writing it again because I've taught you so many times in neoplasia, but a quick recap with all of you. G for what? G for GIST, which is in front of you. Ye ho gaya. Then I told you pick up A and M. A and M was AML. Then I told you ulta, M and A, that is mastocytosis. So simple, AM kara to AML, MA kara to mastocytosis. Then go forward, then talk about ME. ME is going to be melanoma and SE is going to be seminoma. These were all the games tumors. Whenever you go to play a game, you carry a kit. So c-KIT or CD117, finally you've done that. c-KIT or CD117 is seen with GIST. But please note, if there is a chota bacha, if there is a small kid. So for small kids, you have SDH mutation. So I have learnt it as SDH is important for pediatric mutations or pediatric GIST. So very simple, na? SDH for small kids. For small kids, you have SDH mutation, pediatric GIST. This could be a question in pediatrics, of course. So now, whenever this kind of a mutation or this kind of a mutation happens, do you know the problem that is occurring? The problem is that there is an increase in the tyrosine kinase activity. So common sense, if I have to treat these patients, ab dekho, genetic mutation to has happened. I can't do much about the genetic mutation. But because the tyrosine kinase activity was increasing, I can give a tyrosine kinase inhibitor, and that is going to be imatinib. And that is what they ask you in the exam. What is the drug that you use for this particular tumor? And that is GIST. Please note, when I'm talking about imatinib, there are only 2 places in pathology where imatinib will be used. One of them is going to be GIST, and the other one is a leukemia called CML. So the only 2 places in pathology where imatinib is going to come across is going to be GIST and CML, and the concept is the same. In GIST also tyrosine kinase activity increases, in CML also with the Philadelphia chromosome, then also the tyrosine kinase activity increases, which basically means that in both the places the treatment is going to be imatinib. Simple. Now what is the last thing that we are left with? What is the most common site? Because did you notice up till now, stromal word to you read, you said, ha, this is stromal, so this is stromal tumor, okay. But this was gastro and intestinal, matlab it happens in the stomach and it happens in the intestine. Now tell me, what is the most common site? Whatever word comes first is the what I'll give preference to. So the most common site is going to be the stomach. The most common site is gonna be the stomach. Okay with everyone? Finally, if you ask me, ma'am, on the last day, I have like 15 seconds to revise GIST. Can you tell me like that one marker where I can study and I'm sorted with GIST? Yes. This is the set of markers that you have to know for GIST. Very, very important information. c-KIT or CD117, simple na, that was the mutation also, that is the marker also. There's one CD marker more, which is CD34, and then there is something called DOG1. So please remember, DOG has G na, so this is for GIST. This is the most specific marker. This is the most specific marker, whereas jo c-KIT hai, c-KIT is sensitive. So the most sensitive marker for GIST is going to be the CD117. So repeating once again, CD117 or c-KIT is going to be the most sensitive, whereas DOG1 is going to be the most specific. DOG mein G hai, so that is going to be G for GIST, and that is most specific. So that wraps up. If I have to wrap up GIST in 5 bullet points. Cell of origin, cells of Cajal. The most common mutation, CD117, that increases tyrosine kinase activity. So the treatment is what? Tyrosine kinase inhibitor, that is imatinib. Question 4, what is the most common site? Gastro word comes first, so gastro is more common site. Then comes the markers. What is the most sensitive? c-KIT or CD117. What is the most specific? That is DOG1. With that, we wrap up our entire discussion of the stomach, sorted, and we move on to the next part, which is the most important part of GIT, that is the intestine. Starting with the next part of the GI tract, and that is the intestine, which I've already told you is the most important part of this chapter. I've got you a list of topics which we'll be ticking off one by one. That's for our to-do list, I can say. So first, let's start with the malabsorption syndromes. Now, when I'm talking about malabsorption, I basically mean nothing is getting absorbed, right? And if I ask you or someone asks you that what is the hallmark of malabsorption, nothing getting absorbed is fine. Proteins, vitamins, fats, everything's getting lost. But the hallmark feature of malabsorption of the intestine means that fat is not getting absorbed. All the fat is going across in the stools, and that is known as steatorrhea. How will the patient describe to me that all the fatty stools are going on? Patient will say bulky, frothy, foul smelling, all the FFF things, right? Bulky, frothy, foul smelling, and difficult to flush. Flush nahi hoga. So it's sticking to the pan, it's not getting flushed, it's very sticky. That's the FFF description for fat. So if the patient wants to tell me that there is F for fat in the stool, patient will come to me with a description of frothy stools, foul smelling stools, they are not being flushed. These are the kind of stools that the patient is going to describe. So I'm going to tell you 4-5 quick causes of it. The first one is going to be an infective condition called Whipple's disease. Why did I say infective condition? Whipple, it is going to be associated with a gram-positive organism, that is Tropherema whipplei. So a gram-positive organism, the name only tells me. Whipplei matlab it is going to be associated with Whipple's disease, right? How do you do the diagnosis? Can you all see that there are some, pehle to can you all appreciate these are all goblet cells? Goblet cells matlab I'm talking about the intestine. And suddenly below that I can see some little whitish foamy cells. I'm going to see some foam cells. What are these foam cells? They must be macrophages, because I know that if a organism has come into the body, there is one cell which is always going to eat it up, and that cell is going to be the macrophage. So basically foam cells are nothing but macrophage which has eaten up this gram-positive organism. How do I prove it? I'm going to put, and this sentence I have told you so many times is the most important part of Whipple's disease. How do you do the diagnosis? Which cell will you try to catch? Macrophage, because the foam cell was nothing but macrophage. How are you going to stain it? With pus. And in which layer are you going to look out for them? Lamina propria. So when you see pus positive macrophages in the lamina propria, can you see that in the picture? P for pus, P for pink. All these cluster of all these cells have now become pink. The earlier which were looking all foamy, I have put a pus stain, and now all of them have become pink. So pus positive macrophages in which layer? They are seen in the lamina propria, and that is what you need to know about Whipple's disease. So you know, when I'm talking about intestine, please note, when I'm talking about intestine and the examiner says कि अच्छा intestine में foamy cells are seen microscopically, there are two things that should be coming to your mind. Either it is Whipple's or it is TB. How do I prove? And in our country, of course, you know, TB is important. Na? TBs of the intestine is much more common than Whipple's. So for TB, I know one stain which will not be positive in Whipple's. What is that stain? TB ke liye? Common sense, the Zn stain. If those foam cells come out to be positive for Zn stain, it is TB. If those foam cells only come out to be positive for pus and not for Zn stain, means it is Whipple's. How easy. What a common sense thing, but they ask you in the paper. They say there is an HIV positive person showing you foam cells in the intestine. HIV positive mein TB ho sakta hai, right? And foam cells in the intestine means that yes, I will have to do a Zn stain and prove it. So that is the kind of question that comes. So simple, Zn stain hoga to think of TB. Zn stain is not there and foam cells are seen. Think of Whipple's. How will you confirm Whipple's? By putting a pus stain. Pus positive macrophages in the lamina propria. That was the first one reason that you had for malabsorption. There's another condition which you have with malabsorption, and that is going to be the celiac disease, which is known as the very famous gluten sensitive disorder. So my first question is, what are all the market foods that have gluten? Remember, the bro cereals have gluten. barley, rye, oat and wheat. Barley, rye, oat and wheat have gluten, and actually, I've realized gluten has been really been given a bad name, that gluten is causing a problem in these patients. But please note, gluten actually contains a chota molecule. The entire gluten is not a problem. Gluten contains a smaller molecule, and that smaller molecule is going to be alpha gliadin. That smaller molecule is known as alpha gliadin, and that creates a problem. So please note that you also consume gluten, but you usually don't have any problem after consuming barley, rye, oat or wheat. Wheat is something which is our staple diet. We have it all the time. We don't have any problem after barley, rye, oat and wheat. But why do these people have a problem? Because they have HLA, DQ2 and DQ8 polymorphisms. They are associated with HLA, DQ2, DQ8 polymorphisms. Other than that, they have also been shown to have certain elements of mutations, or usually other kind of HLA polymorphisms. So that is why they are responding. They are having a problem with gluten, whereas we are not having a problem with gluten, because thankfully we don't have these HLA polymorphisms. So the next question asked is it a CD4 T cell problem or is it a CD8 T cell problem? So remember, both are involved in the pathogenesis. CD4 T cells and CD8 T cells both are gonna be involved in the pathogenesis. Very, very important. So now when T cells, now I know one thing from my immunity, T and B cells are cousin brothers. If T cells are getting involved, B cells will also get involved. And if B cells will get involved, antibodies will form. So what are the antibodies that are going to be there? Gliadin tha, gluten, gliadin, so gliadin ke against antibodies. Then there is antibody against TTG. What is TTG? It is tissue transglutaminase antibody. It is tissue transglutaminase antibody, which you need to know. And finally, we have something called endomysial antibodies. These are all the different kind of antibodies that we have, and not always, but they are usually of the IgA type. Usually, again I'm saying, there can be other categories also, but they are usually of the IgA type. Repeating once again, anti-gliadin, anti-TTG and anti-endomysial. So I realize this is going to be a proper CD4, CD8 T cell problem also, and this is going to be a B cell problem also, because that is going to result in the formation of the antibodies. Where are these antibodies going to go and attack? Which part of the intestine will they attack? So think logically. Someone consumed gluten, brow cereal consume kara. The brow cereal, after entering into the body, resulted in the formation of lots of these antibodies. These antibodies are going to go and attack what? They will attack the duodenum. These antibodies will go and they will attack the duodenum. So please remember, celiac disease is going to show you the duodenal attack. I've got you a normal duodenum over here, and I've got you, again and again I'm saying duodenum, because I'm going to tell you in a while that duodenum mein problem hai. I've got you a normal situation over here. Normal mein, I hope everyone can identify that a normal intestine shows you these villi. What are these? As I've told you, these finger-like. I've told you their name. Their name is villi. And what are these round things that you have? The round hota hai crypts. We all know this, na? There are villi and crypts that are present. So now imagine if antibodies come and attack all of this. I just told you that antibodies are going to come and attack all of this. So all these villi will be gone. Like exactly how we described it over here. All these villi are going to be gone. So can I say the villi atrophy is going to occur? The first thing that shall occur is going to be villus atrophy. The villi will flatten. So imagine someone comes and breaks your body, and are you just going to sit back and listen to that insult? No, you will fight back. How do you fight back? These scripts say that, okay, wait, we will try to fight back. We will start becoming more in numbers. So the next thing that happens is crypt hyperplasia. So basically one thing goes less and one thing goes more. These villi that you were seeing over here, these villi are gonna flatten out. They are gonna be less, and as soon as they flatten out, someone from below is gonna come and compensate. So I can say crypt hyperplasia is a compensation. But think logically, if I decrease one thing by 1 mm and increase another thing by 1 mm, so overall the thickness is the same, na? If earlier, for example, this was 2 mm, now also the thickness is 2 mm. Even if villi were flattening, something else is making up for it. So can I say that the overall thickness shall remain the same, hai na? And finally, because you were talking about B lymphocytes, T lymphocytes, you will see that there are a lot of intraepithelial lymphocytes, especially CD8 T cells. If they ask you these intraepithelial, IELs, intraepithelial lymphocytes, they are going to be of which type? So these intraepithelial lymphocytes are going to be of the CD8 T cells, and this together is known as the Marsh classification. This is a question that you get in medicine. What is Marsh classification? It includes number 1, the villi becoming flat. Who is compensating? The crypt is compensating, and there are intraepithelial lymphocytes. These 3 things make up the Marsh classification. I hope everyone's okay with this, because now I can ask you that how are you going to talk only about the duodenum in this? Yes, this is a DDDD disease. What is DDDD? This patient will number 1 have diarrhea. Whenever he will consume anything to do with barley, rye, oat and wheat, he will end up with diarrhea. Which part of the intestine is most commonly affected? Most commonly duodenum is affected. So again, think logically, what gets absorbed from the duodenum? Iron, na? So this means that there is iron absorption is going to be hampered. Iron absorption is not going to occur. This means the patient is going to land up with iron deficiency anemia. If duodenum is problematic, iron is problematic. The next, they are also associated with a skin disorder called dermatitis herpetiformis, because if I go to the skin chapter, I know dermatitis herpetiformis is also associated with IgA, and celiac disease is also associated with IgA antibodies. I just now told you celiac disease shows you lots of IgA antibodies. So now when both of them are to do with IgA, they tend to occur together. So celiac disease in the intestine is because of IgA, dermatitis herpetiformis in the skin is because of IgA. Both of them occur together. So how are you gonna treat a patient of dermatitis herpetiformis? Please note, for the treatment we have another drug that is known as dapsone. What is dapsone? So it's a drug for treatment of dermatitis. Another D. So DDDD kya hai? D for this patient is going to have diarrhea. Most commonly duodenum is affected, so deficiency of iron occurs. Dermatitis can occur in the skin. Dermatitis herpetiformis ka treatment is dapsone. But this is the treatment of dermatitis herpetiformis. What is the treatment of the celiac disease? Intestinal problem का क्या treatment है? Simple. Tell the patient, listen, you cannot have the brown cereals, barley, rye, oat and wheat. You cannot have that. What you can have is rice and maize. Rice and maize have very minimal amount of gluten, so rice and maize you can have. And apart from that, you will also have to keep this patient on steroids. You can't just tell him only lifestyle or only diet is not enough. You have to keep him on steroids as well. But still you have to keep him under follow-up. You know why? Because these patients tend to have a risk of cancer. They have a risk of cancer, and that cancer is known as EATL. I have learned कि ये eating से problem है ना. Celiac disease is eating वाला problem, gluten eating problem. तो eat वाला lymphoma is what is going to happen. What is eat? There is enteropathy associated T cell lymphoma. There is enteropathy associated T cell lymphoma. So to make your life a little easy, I have told you this is with the problem of eating gluten. So the tumor that occurs is also EAT, that is enteropathy associated T cell lymphoma. I hope everyone's okay with this. You've understood the second disease, that is the celiac disease. Now I'm going to tell you the third malabsorption, which is known as environmental enteropathy. Pehle focus on the name. It is something to do with environment. You know what with the environment? E for environment, E. coli. E for environment, E for E. coli. This malabsorption is to do with E. coli. So if I know the cause, I know the treatment. This means, ma'am, later on the treatment you're going to tell me is antibiotics. Because if the cause is E. coli, the later on treatment shall be antibiotics. So E for environmental, E for E. coli I have understood. The other name is tropical sprue. So T for tropical sprue, T for total intestine. Total intestine matlab over here is not just the duodenum. Over here, it's the duodenum that is affected, the ileum that is affected, and the jejunum also that is affected. So all total intestine is going to get affected. Compare it with celiac disease. In celiac disease, it was DDDD. Celiac disease mein only duodenum was affected. Here, the duodenum, ileum, jejunum, everything is affected. So which anemias? Duodenum effect hua, so iron will not get absorbed. Iron deficiency anemia. Ileum is gone, so B12 will not get absorbed. And jejunum is gone, so folic acid will not get absorbed. What is this anemia known as? When B12 and folic acid is deficient, it is known as the megaloblastic anemia. So yes, I realize that these patients are going to have both. These patients are going to have iron deficiency anemia also, megaloblastic anemia also. That means that in celiac disease, it was only duodenum, only iron deficiency, whereas in tropical sprue, total intestine will occur, total anemias will occur. Sab kuch total hoga. And is there any risk of cancer? no, ये simple bacterial infection है, give antibiotic and sorted, no genetic problem, nothing. It's a bacterial infection, so you're sorted, and that is the third malabsorption. The fourth and fifth are very simple. You just have few infections. This infection is a previous year AIMS and NEET PG question, that is Cryptosporidium. So Cryptosporidium is a parasite. You've read it in your microbiology, very important. How do I identify the pathology photo of Cryptosporidium? You will always see these dot-like organisms. You will always see these dot-like organisms, and where are they present? They are going to be present along the brush border. They are going to be present along the brush border. So they are not, see, if you look carefully, they are not inside the cell like this. No, they are stuck. They are stuck on the brush border. Here also they are stuck on the brush border. That is what you need to know about Cryptosporidium. There's one more infection that can cause malabsorption, Giardia. If you want to know the full name, revise Giardia lamblia. Giardia lamblia, how do you identify that in the intestine? Firstly, in micro, you have seen these kind of pictures. Remember, you used to call it the angry old uncle, the angry old man. Yes, so pear shape. You've seen this pear shape, but you've seen the front view. If I show you the front view of my hand, it's going to look like a pear, but if I show you the side view, it's going to look like a sickle. So till the time they were showing you the front view, it was looking like a pear, but now they are showing you the side view. In pathology, they show you the side view. Micro mein they were showing you front view, pear. Pathology mein they are showing you the side view, so that becomes the sickle. So you can also call it a sickle shaped organism. And where is it present? Most important, lamblia is in the lumen. Please remember, lamblia is going to be in the lumen. Very, very important. The location of these is important. Remember, Cryptosporidium is along the brush border, and Giardia lamblia is going to be floating in the lumen. Very, very important. Do you remember what in microbiology was its motility? It had the falling leaf motility. Very important question of microbiology that you have to know. It has the falling leaf motility. Sorted. This is done. We are done with all the different malabsorptions. The first topic of intestine seems sorted for us. The next topic that we had decided was we'll do the ulcers of the intestine, right? We are going to do the ulcers. In ulcers, I will take up ulcers and IBDs together because IBDs also show you ulcers. But first, I want to show you three pictures to do with ulcers of infection: TB ulcer, typhoid ulcer, amoeba ulcer. Jaldi se revise their locations with me. What is their shape like? So TB ulcer is going to look transverse like this. TB ulcer is going to look horizontal, transverse like this, and typhoid ulcer is going to look long like this. How will I learn this? Dekho, typhoid. How do you wear a tie? Tie is always worn longitudinally, na? So tie hamesha long hota hai. Therefore, typhoid ulcer is going to be a longitudinal ulcer because tie is worn longitudinally, and then automatically TB ulcer becomes a transverse ulcer. The difference is done. Now we come to amoebic. When I say amoebic, I'm talking about Entamoeba histolytica. I'm talking about Entamoeba histolytica, and I can see the very famous flask shaped ulcer coming out here. This is again a very important microbiology image. So three ulcers: TB is going to be transverse, typhoid is going to be longitudinal like the tie, and amoebic ulcer is going to be a flask shaped ulcer. These were the three infective ulcers. Now I'm going to start off with a disease that also shows you ulcers, but that group of diseases is known as IBDs, inflammatory bowel disease. I will try that I give you 2 slides for each and we are sorted, okay, so that we can do it in a very rapid, concise and a high yielding manner. When I'm talking about inflammatory bowel disease, there is something called Crohn's disease and there is something called ulcerative colitis. So remember, Crohn's disease ka mnemonic is what? I have that in front of me, Sister Mac. I'm going to start off with Sister Mac first. One alphabet we will complete. An entire Crohn's disease beautifully is inside Sister Mac. For ulcerative colitis, I have an even simpler mnemonic, and that is ulcerative colitis. Okay, so should we start? Let me begin first with Sister Mac for Crohn's disease. So please remember, this condition tends to show you the famous skip and skin. What is skip and skin? That means that when I'm talking about the intestine, this disease does not occur everywhere. This disease occurs in certain locations. Disease, normal, disease, normal, disease, normal. So it's going to skip. It's a skipping kind of a disorder that we are going to have. So please remember, it's an S for skip lesion. Also, ye to intestine hai na? Do you know Crohn's disease shows you skin nodules also? So I have learned S for skip and skin. Skip and skin means skip lesions are there in the intestine. Skin nodules are also noted. Next, we come to which part of the intestine am I talking about? Often it is the ileum. So remember, the most common location where it is going to act, I for ileum. Why does it act? Is there any fungus associated with it? Is there any antibody associated with it? Yes. Please remember, this is associated with S for Saccharomyces cerevisiae. This is a fungus. This means the antibody is going to be anti-Saccharomyces cerevisiae antibody. It is ASCA positive. Many students ask me, ASCA kya hai? Which antibody is it? I've told you it's associated with the fungus, Saccharomyces cerevisiae. So anti-Saccharomyces cerevisiae antibody is noted. That's the cause. Next, what is the radiology sign that you see? It's something known as S for string sign. Have a look at this. You will see that the intestine has been converted into a string, hai na? So S for the string sign. Very, very important in Crohn's disease. Very important. And what kind of a preparation is this? This is a barium study, na? So what you see is going to be a barium study. Coming back, so sister, skip and skin, ileum, Saccharomyces cerevisiae and string lesions. Now we come to the T and E. If you ask me how much of intestine is affected, mucosa, submucosa, I'll say everything. This is a full thickness. Full thickness means transmural, entire, T for transmural, E for entire wall, full thickness is affected, resulting in fissures and fistulas. And finally, which is the organ which is never ever involved? So last wala, rectum is spared. So remember this question, the most common is going to be ileum and the rectum is always going to be spared. So what all have we done? Sister to ho gaya, jaldi se quick revision. S is for skip and skin lesions, I for most common ileum. What is not affected? Rectum is never affected. How much of intestine is affected? Full, entire intestine, entire layers are affected. And what is this fungus? Saccharomyces cerevisiae. What is the radiology sign? String sign. Now I come to sister MAC. So what is MAC going to be? Pathology to padha nahi. What is pathology? What is microscopy going to show you? Microscopy can show you the non-cageating granulomas. Microscopy is going to show you non-cageating granulomas. Very important, because now make a rule. In the intestine mein if I would have mentioned cageating granuloma. In our country, as soon as I mentioned cageating granuloma, from the brain to the toe, we think of TB only na in our country. But over here, I'm talking about non-cageating granuloma in the intestine. Have a look at this picture. You don't see any caseous necrosis. And ye wala photo na, let me tell you, this is the most high yielding photo of Crohn's disease that they have. They don't have any other picture of this granuloma other than this. So they will always give you the same picture. So remember, you can see that, yeah, this is the intestine and I'm noticing a granuloma over here. This I've got you on high power. How did I identify a granuloma? I identified it with the presence of these giant cells. With the presence of these giant cells, I've been able to identify. Over here also, I can see a giant cell. So ye hai non-cageating granuloma, which is the microscopic finding of sister MAC. What is with A? Remember, the first thing that I told you was these diseases also have ulcers. Until now, I have not spoken of an ulcer. Now I do. The first lesion of how this disease started was an ulcer called an aphthous ulcer. And gradually that becomes like a snake. So serpiginous ulcer. So quickly I'll draw it. So for example, if this is the intestine, initially this is the ulcer, this is the ulcer, this is the ulcer, this is the ulcer. Skip hoga na. So ulcer normal. So aphthous ulcers are there. Gradually, these ulcers extend and they start meeting each other. Now is it started looking like a snake, serpentine. So initially you have aphthous ulcers and gradually they are going to progress into a serpiginous ulcer. Finally, coming to the 3 C's of sister MAC. What is the first 2 C's which I'm going to show you as pictures? If you look at the outside of the intestine, it looks like a bag of fat. The outside of the intestine is all yellow. This is known as creeping fat outside. If I peep inside into the intestine, I'm going to see the cobblestone. Less a stone appearance are. I'm going to see the cobblestone appearance. So repeating once again, if you see the outside of the intestine, it is going to be creeping fat. If you see the inside of the intestine, it is going to be cobblestone. And finally, coming to the pathogenesis, what is the cytokine over here? It is an increase in TNF alpha. So socho, why am I wanting to tell you the cytokine? In rapid review, ma'am, we should be very concise, but you should know treatment, na? So for knowing the treatment, you should know that we can give infliximab. we can give infliximab, and that is going to help in the treatment because that is going to be anti-TNF alpha. That is anti-TNF alpha. So yes, of course, if I know the cytokine, I know the treatment of choice. So repeating once again, sister ka humne kar liya tha, the review. Now we're going to do the review of MAC. What is MAC? M for what? Microscopy, non-caseating granuloma. A for the first lesion, aphthous ulcers, they progress to serpiginous ulcers. C for three things. Outside, if you see the intestine, you will see creeping fat. Inside, if you see the intestine, you will see the cobblestone appearance. And cytokine, if you ask me, TNF alpha. We are done with Crohn's disease. We move on to ulcerative colitis. And I told you the mnemonic for ulcerative colitis is ulcerative colitis. So the first word is ulcerative. Ulcerative tells me that, of course, there is going to be ulcers. So ulcers, let me draw. It's not just ulcers. You know, if some ulcer matlab damage na, someone is trying to damage your body, you're not going to keep quiet. You are going to fight back in the form of these regeneration. You will say, okay, you're trying to damage me, I will fight back. And that regenerating mucosa is referred to as a pseudopolyp. So remember, pseudopolypic question is very important. Pseudopolyp is seen in Crohn's or ulcerative? It is seen in ulcerative. Means if there is an ulcer, I will fight back. Then an ulcer, I will fight back. Then an ulcer, I will fight back. So that fighting back and that regeneration is a pseudopolyp. That is why I didn't call it a true polyp. It's not a polyp. It's not a genetic problem or a polyp that has happened. It's a pseudopolyp. Means it's a condition of fighting back by the body. So ulcerative to have understood, ulcers and pseudopolyps. What is colitis? Let us go one by one. Keep comparing it with Crohn's, okay? Crohn's was skip lesion. Ulcerative is continuous lesion. Crohn's mein rectum was never involved. In ulcerative, often rectum is involved. So these are continuous lesion. Often rectum is affected. Now, continuous, you'll say, ma'am, okay, it started from the rectum. And is it going to involve everywhere? Yes, I've got you a diagram. See, it has started from the rectum over here. You can all appreciate it has started from the rectum. And how is it going to progress? It is now going to go in a backward direction and in continuous. Now, it's a continuous lesion. It is going to involve the entire intestine. But in which direction did I go? I went from here in a backward direction, retrograde involvement. This has resulted in something known as retrograde involvement that you see. It's in this direction that the involvement is occurring. So, okay, full intestine affected. Then what about small intestine? Will the small intestine also get affected in the same manner? Yes. Back mein intestine also gets affected. That is known as backwash. Backwash because backward movement, and ileitis because ileum is affected. So remember, there is also something known as backwash ileitis. So what did I tell you? C for continuous involvement. O for often rectum. It starts from the rectum, it goes in a backward manner, that is retrograde involvement. Then it goes to the small intestine, so backwash ileitis. Understood? So as a result of which, how is your barium study going to look like? The lead pipe appearance is very, very famous. Have a look at this picture. On a barium study, we can always see how the intestine has become like a lead pipe. Kaisa hota hai intestine? Intestine is usually like this, pouch, 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 hai na? Now that has converted into a straight, rigid lead pipe. Very, very important point for ulcerative colitis. Which immunity is responsible for this? We've done it so many times. The immunity responsible for this is P. ANCA. Can you quickly recall for me prior to this, if you've read the liver chapter, or after this you're going to read the liver chapter, there is one disease in the liver also that is P. ANCA positive, and that is primary sclerosing cholangitis. So these are the two gastrointestinal and hepatobiliary things. Ulcerative colitis and primary sclerosing cholangitis, both of these are P. ANCA positive. Next, is there any complication? Yes, T for toxic megacolon is a complication that can occur. Next question they will ask you, does it have a risk of cancer? Of course. Even Crohn's had a risk of cancer, and even ulcerative has a risk of cancer. The risk of cancer is present everywhere. But what I'm going to tell you next, or the only place in the entire universe where I say कि smoking का भी कुछ benefit है, or smoking can be protective or preventive against something, and that is ulcerative colitis. So remember, many people who have ulcerative colitis, if they smoke, they will always say that after smoking my symptoms are relieved. So smoking can be protective and can also be one of the relieving factors in ulcerative colitis. So देखो, colitis pneumonic is done. Should we do a recap? C is continuous lesion starting from the rectum and going backward. L for lead pipe appearance. Immunity is P anchor. Complication is toxic megacolon. Increased risk of cancer. Smoking is preventive. Now tell me the treatment also na. What is the treatment of ulcerative colitis that you have? So the treatment of ulcerative colitis is going to be 5-amino-salicylic acid and 6-MP. That is the treatment that you have for ulcerative colitis. What was the treatment for Crohn's disease? TNF-alpha wala, infliximab. Here you have 5-amino-salicylic acid and 6-mercaptopurine, that is 6-MP. That is the treatment that we use for UC with smoking having a protective action. Done with this? Yes. Can we move forward? The next topic that we have to do in the intestine are polyps. Now, if you ask me on the last day, I don't have 1 hour of rapid review of GIT to do, ma'am. Can you help me with just 5 minutes of what can I study in the intestine chapter? 5 minutes mein study polyps. That is how important it is. It's the first most important topic of this entire chapter. So please note that polyps are of two types, which are not going to cause cancer in the intestine, which are going to cause cancer in the intestine. So note two types of polyps you have, which are not going to cause cancer. Number one, hyperplastic. They will happen, but they will never cause cancer. Second one is hamartomatous. Now, if you say on the last day that, ma'am, now 5 minutes bhi nahi hai, I have 1 minute to do intestine GIT chapter. What should I do in 1 minute? I will say in 1 minute, do hamartomatous polyps. That is how important it is. So let me start off, and to simplify your life, I've got you a table. If you do this table, what are we going to do? I'll tell you the names of all these hamartomatous polyps. I'll tell you their genetic defects, and whatever photos I have, I'll keep scanning through those. Okay? So let's get going. When I say the first one, I'm talking about hamartomatous polyps, and the first one is JRP, juvenile rectal polyp. Juvenile rectal polyposis. Please note, in juvenile rectal polyp, the defect is going to be SMAD2, SMAD4. SMAD2, SMAD4, and also one more if you can learn, BMPR1. And if I have used the word juvenile, तो मतलब age क्या होगा? You will say the age is going to be juvenile, less than 5 years, and if rectum, तो rectum मतलब there is bleeding per rectum. So repeating, juvenile word I have understood, juvenile मतलब less than 5 years. Rectum word I have understood that there is going to be a polyp in the rectum. So how have I learned the genetics? Everything about juvenile rectal polyp is juvenile. Matlab, it is going to be age also less than 5. Look at the genetic numbers. They are also all chota numbers. SMAD2, SMAD4, BMPR1. They are also less than 5. So age is also less than 5 and the genetic numbers are also less than 5. That is how juvenile it is. Rectum, matlab, there's going to be bleeding PR. But you'll say other than rectum, nothing else, ma'am? No, there can also be an additional finding in these patients. They can also have digital clubbing. They can also have clubbing. So you might notice this additional finding. Now the question that came in the previous year was, iska microscopy kaisa hai? So juvenile rectal polyp is going to show you cystically dilated glands. Juvenile rectal polyp is going to show you cystically dilated glands. All of you can appreciate these huge glands over here and over here. They are all cystically dilated, matlab big glands. And let me tell you, this was a NEET PG question that came in first time. This same picture, they'll give you a 5-year-old boy and the 5-year-old boy has bleeding PR, and the same picture came. This was a question that came in NEET PG 2019. After that, the same question was repeated in FMG 2020, and let me tell you, the same question has now come in NEET PG 2023 as well. So please note that this 5-year-old, but this time the only difference that happened in the 2023 exam was कि photo नहीं दिया था. They described it. They said there are big glands, there's a 5-year-old child, there's a rectal polyp. Even without the picture or with the picture, 5-year-old child, rectal polyp, there is nothing other than juvenile rectal polyp that I'll think of, and they'll ask you which kind of polyps are they. They are hamartomatous polyps. ठीक है? Moving on to the next, Peutz Jeghers polyp. Everything about this is 11-11, means if they ask you that what is the age of onset is going to be 11 years. And if they ask you what is the genetics, you will say it is STK11 or LKB1. So as I said, everything is 11-11. Peutz Jeghers mein 11-11. Age is also 11 and the genetics is also 11. After that, you will say, okay, I'm talking about Peutz and Jeghers, right? Peutz and Jeghers is the name of the disease, na? That is your mnemonic also. P for what? You can see pigmentation. JE for what? You can see jejunal polyps. Where do the polyps occur? They are going to occur more in the jejunum. So repeating once again, what do you see? P for what? P is going to be for pigmentation. Can we all notice this pigmentation that she's having on her lips, on her mucosa? So P for pigmentation. And JE for what? JE is going to be a condition of jejunal polyps. JE for jejunal polyps. And how do these polyps look like? The very famous tree wala Christmas tree polyp. So either they will use some tree wala word. Either they will say tree polyp, or they will say Christmas tree polyp, or they will say arborizing. Arborizing also means tree only. So something to do with the tree is going to be mentioned over there. So repeating, we have Peutz Jeghers, P for pigmentation, JE for jejunum, polyps are going to be there, and they'll say, okay, whenever a tree is made, a tree always has branches. So, what are the branches that you have? Please note, these branches are made up of smooth muscle. These branches are going to be made up of smooth muscle. So repeating once again, when I have the Peutz Jeghers polyp, we have pigmentation and arborizing polyp, and everything is to do with 11 and 11. Moving on to the next, we have two syndromes that we have over here which are associated with P10. Cowden syndrome is also associated with P10, and Benayan-Ruvalcaba relay syndrome is also associated with P10. You'll say, ma'am, firstly, both of them have polyps? Yes, so I'll write polyps over here. The day I am able to learn Benayan-Ruvalcaba relay syndrome, such a difficult name, a person goes half mad while learning this name only. That is how I have learnt it, that the name is only so complicated and so mind exhausting. So there's going to be mental retardation, intellect disability that is going to be there. So Benayan-Ruvalcaba relay syndrome, naam yaad karte karte, the person has only lost on his intellect. So mental retardation happens. What happens in Cowden? Do you remember a mnemonic? P10, chromosome 10, Cowden. We used to do that 10, 10, den rhyming. P10, chromosome 10, Cowden. Where have we studied? Neoplasia chapter. So we had studied that whenever there is chromosome 10 and there is P10, the Cowden syndrome will occur. And what all does Cowden have? I told you a very simple thing. If you guys remember, I'm going to repeat it once again for you. What did I teach you for Cowden? P10 ही mnemonic है, तो दोबारा पढ़ लेते हैं. What do we have with P10, guys? P से let's start from N. N से क्या है? Endometrial cancer. T for two things, thyroid cancer and tricholemomas, and P for, एक तो simple, P से you make polyp, little complicated, P you change into a B and that is breast cancer. P you change into a B and that is breast cancer. So please remember the rhyme first, P10, chromosome number 10, Cowden. क्या है? P10, chromosome number 10, Cowden. That is 10, 10, den. And what are the tumors in it? The tumors are going to be P10. So N matlab again endometrial cancer, T for thyroid cancer and tricholemomas, P for polyps, and P को B बनाया, that is going to be breast cancer. So this is what you have for Cowden. For Benayan-Ruvalcaba also it is P10, but the name is only so mentally exhausting, so patient is also mental retardation. There's another syndrome called tuberous sclerosis. I hope you all remember. There is something called TSC1 and 2 genes, TSC1 gene and TSC2 genes, which are present on chromosome 9 and chromosome 16. They are responsible for TSC, tuberous sclerosis. They also show you hamartomatous polyp. Guys, I want to ask you a question. In tuberous sclerosis, which is that heart tumor which is very, very important? Cardiac में क्या होता है, which I have also made you do in this rapid review? Cardiac has rhabdomyoma, है ना? Rhabdomyoma shows you tuberous sclerosis association. Coming to the last one, Cronkhite Canada syndrome. Finally, going to Canada. So finally, after reading so many syndromes, ma'am, I have gone old. Reading this table only, I have gone old, because this is gonna happen above 50 years of age, and this is the only one which which is non-genetic. It is non-hereditary. So ultimately I say that for everything, देखो juvenile rectal के लिए you had all juvenile वाला genetics. For Peutz Jeghers you had STK11. For Cowden and Benayan Ruvalcaba you had P10. For tuberous sclerosis you had TSC, TSC. Everywhere you had a gene. But for Cronkhite-Canada syndrome, the only non-hereditary polypoidal syndrome that you have, and Canada jate jate you have gone very, very old. So this means that if you've not got Canada citizenship as your hereditary, it's going to take you many, many years to earn it. Okay, so this is not Canada ka property, and citizenship has not come to you hereditary from your parents. You will have to earn it, and to earn it, it will take you many years, after 50 years. So what is going to be the patient's problem? Polyps of course are going to be there, but imagine, what does an above 50-year-old person have? An above 50-year-old person, anyway, just forget this disease. Think of yourself at the age of 50 and think of your hair, skin and nails. Of course, at that age, we are going to have hair loss. Of course, at that age, my skin is going to show me pigmentation. And of course, the nails are going to be very, very thin. So, ye to common sense tha. Easy to learn. Above 50 years of age, these patients show you hair loss, skin pigmentation and nail atrophy, which any 50-year-old person will show you. Along with that, there are polyps. And this is not at all genetic, non-hereditary. So Canada jane took many, many years. That is above 50 years of age. These are all the hamartomatous polyps that I wanted you to know. But whatever I have taught you till now is non-neoplastic, because what I shall teach you now is going to be neoplastic. Neoplastic matlab adenoma. Pehle all of you make a promise with me. This question many students forgot in the recent exams. As soon as the word adenoma, anywhere in the GIT, adenoma esophagus, adenoma stomach, adenoma intestine, adenoma word comes in the GIT and immediately alarm. Alarm shall ring in your mind, because adenoma shall be precancerous. Adenoma is definitely going to be precancerous. Very, very important. So what are the types of adenomas? बहुत simple है. अगर ऐसे गोल गोल tubules दिखेगा round round, you will say tubular adenoma, precancerous है. If you say these finger-like villi, you will say, okay ma'am, villous adenoma. Anywhere adenoma coming, so now I'm not gonna say it again and again. This entire table is precancerous. समझ जाओ, ठीक है? This entire table is precancerous because everywhere I'm using the word adenoma. So if I use the word tubular adenoma, it is round tubules. If I say villous adenoma, they are proper villi. If I use them together, tubulovillous adenoma means they are showing me tubules also, they are showing me villi also. दोनों का combination. Out of these three, tubular adenoma, villous adenoma, tubulovillous adenoma, which has the maximum risk of cancer. Risk of cancer is there in all, but maximum risk of cancer, so remember, villous is the villain. Villous is the villain. It is very, very dangerous. So this villous adenoma is the villain over here. It has the maximum risk of intestinal cancer. It has the maximum risk of intestinal carcinoma. Yaad rahega, villous is the villain. Okay. Now we come down to a condition known as, so I'm going to draw a line over here, because now I'm going to start with something which is very, very important, and that is FAP. What do you mean by FAP? Firstly, I think everyone knows FAP is familial adenomatous polyposis. Break karo, theek hai, aise nahi yaad hoga. FAP, familial, okay ma'am, familial matlab genetic. So what is the genetic? From FAP, AP, I can learn the gene is APC. APC कर देंगे तो FAPC याद कर लो. FAP, तो APC is the gene, and F is for 5. APC gene on chromosome 5q. APC gene on chromosome 5q. How simple. So the way you write FAP, AP you're going to take up and APC becomes the gene and F becomes chromosome 5. So familial word I have understood. Okay, familial I've got it. Adenomatous, polyposis. So polyposis matlab kitna polyps? Minimum how many polyps? Minimum 100 polyps. Minimum 100 polyps. So you'll say, okay ma'am, F for familial, I've understood. P for polyposis, I have understood. A for adenomatous. Adenomatous, did I say? Alarm bell ring karo. Adenomatous matlab risk of cancer. So they will ask you how much risk of cancer. Remember, 100% risk of cancer. So I have learned that familial adenomatous polyposis is everything 100. Minimum polyps are also 100. The risk of cancer is also 100. Okay? Now we come down to the different types. There's a classical FAP, there is a Turcot syndrome and a Gardner syndrome. Okay? So when I say classical FAP, you will say, ma'am, in classical FAP there are just polyps. मतलब वही अपना 100 polyps वाला situation. And along with that there can be some involvement of the eye. There is congenital hypertrophy of retinal pigment epithelium. The eyes का retinal pigment epithelium that can be hypertrophy, छोटा सा problem. Otherwise classical मतलब only 100 polyps. Turcot syndrome में how I want you guys to learn Turcot is divide it into ter and cot. मतलब cot will remind you of something to do with colon. Colon में क्या हो रहा है? Colon में we are having polyps, FAP. And ter will remind you of turban. Turban means brain tumors. Ter will remind you of brain tumors. And you know which brain tumor is very, very commonly seen over here? There is the blastomas. That is medulloblastoma can be seen. Glioblastoma can be seen. So ultimately I realize the blastomas are common over here. Moving to the next, we have Gardner syndrome. Gardner syndrome में से gardening करना है. Polyps तो होगा, of course. Gardening. Gardening is what? One layer of soil, second layer of soil, third layer of soil. तो body में gardening करना start करो. What is the first layer of your body? That is the sebaceous, the skin, sebaceous cyst. First layer is skin, so sebaceous cyst. Skin के नीचे fibrous tissue. So these patients have fibroma. Below the fibrous tissue you have bone, so osteoma. And with osteoma you're also going to think of lots of teeth, supernumerary teeth. So Gardner syndrome में gardening करा. Repeat, skin तो sebaceous cyst, fibrous tissue fibroma, then you have the bone osteoma, and then teeth. So remember, FAP is of how many types? If I have to tell you like 5-6 bullet points of FAP, तो FAP के लिए पहले तो the genetics, APC on chromosome 5. How many polyps? 100. What is the risk of cancer? 100. Classical में only polyp, little bit eye problem, that's it. Turcot में ter and cot. Cot will be something to do with colon, which is FAP itself, and ter for turban, brain tumors. Gardner में you're going to do gardening of the skin. All in all, whether you talk about, just FAP, or you talk about classical FAP, or Turcot FAP, or Gardner FAP, या कोई भी type of FAP, I hope you all remember this had an autosomal dominant inheritance. All these, everything to do with FAP, go back to your genetics chapter, all of them are autosomal dominant. Now we've spoken so much about cancers. Okay, this can cause cancer, that can cause cancer. So all the adenomas, tubular, villus, tubulovillus, FAP, sab kuch cancerous hai. But what cancer am I talking about? Of course, I'm talking about intestinal carcinoma. So when we talk about intestinal cancer, there are two main things that you have to know. First, what is the genetics? And second, what is the lab diagnosis? When I'm talking about intestinal cancer, it did not occur overnight. It's not that one day the person was totally normal and the next day he woke up with a cancer. Not at all. This is a sequence. Can you see that? Adenoma carcinoma sequence. It's happening in multiple steps. The patient will first have an adenoma, then the person will have a carcinoma. So it's not a single step mechanism. It is a multi-step carcinogenesis. This is going to be a multi-step carcinogenesis. And how do I know what are the different genetic problems happening? You will learn it as AK, but not AK47. You will learn it as AK53. And what is AK53 that you have? The first problem to occur is A for APC gene mutation. So A for APC gene mutation, K for KRAS mutation, and 53 for P53. 53 for P53. Now you say, ma'am, 5 and 3 to ho gaya, odd numbers are done. What about the even numbers? I also want AK24. 2 and 4 are missing. So please remember, SMAD2 and SMAD4 are the other genetics that can be problematic. So basically all the even numbers, all the odd numbers, that is the gun that you have made. So first genetic mutation to occur is going to be APC. The second genetic mutation to occur is KRAS. So they will tell you to put it in the order. All that you have to know in the exam, ke AK, pehle 53 pe focus karo, after that you focus on the even numbers. Okay? So first it is going to be APC, then it is going to be KRAS, then it is going to be P53, and then if they ask you, it is going to be SMAD2 and SMAD4. So intestinal cancer occurs after so many mutations. And do you know how do you do the diagnosis? Please remember, on a barium study or a barium enema, we see the very classical, the apple core deformity. We see the apple core. Apple core matlab not apple like this. eaten up apple. Someone has eaten up that apple. So it's now looking like this. The apple core deformity is going to be noted when I talk about the barium study. What is the tumor marker? This we have done way back in your neoplasia chapter also. The tumor marker is CEA, carcinoembryonic antigen. And what is the testing that you do for occult blood? Occult blood means hidden blood. Occult blood basically means very tiny little blood. Occult matlab hidden. So very little amount of blood that is coming in the stools. How will you do a test? Little, itna little hai that if you look at it with your eyes, you can't see it. But when you do a test, you will find that yeah, a few drops of blood was coming out in the stool, and that test is the GOAC test. So whenever in the question it's written someone's GOAC test is going to be positive, it means that person is going to have blood in the stool. So repeating, barium enema shows you this apple core defect. Next you have tumor marker, that is CEA, and finally the GOAC test is positive. So for intestinal cancer, please first remember AK53, which is very important, and then do remember these diagnostic modalities. On that note, we have finished our rapid review, that entire GI chapter.